Good morning. Welcome to the 13th Annual UI Health Transplant Conference here on the campus of UIC. My name is Dave Dreyfus, along with my colleague in crime, Samantha Mock, who is on the back end of things, who will be presenting later today, and is the other outreach coordinator. We'd like to welcome you and thank you for joining our live stream. This is certainly a difficult time, pandemic or not, with the help of technology and our digital services here at the UIC campus. We are able to bring you this conference live stream. All of you know that I am a people person. I love my job. I love talking to people. I sincerely miss all of you. Pandemic, social unrest, and politics casting a dark cloud over us. I hope you find that this conference is a stepping stone or a means of catalyzing the start of normality, coming back to normalcy and working on transplants and working people in the dialysis centers. Many lives have been lost nationwide, worldwide. And I bet each and every one of you that are live streaming right now has been affected or has had a person, a relative, a family member, a friend that's been affected by the COVID-19 pandemic. Here at UI Health, we've lost several members of our staff. One that's truly close to the heart of our transplant team, and Dr. Benedetti is an OR nurse by the name of Maria Lopez. And in talking to Dr. Benedetti, we've decided that we are going to dedicate this conference in her memory. And at this time, I would like you to possibly just bow your head, take 10 minutes or 10 seconds of a moment of silence and prayer for all those that have died nationwide, worldwide, and here locally. So please take a few seconds and pray. This is very, very new to me in terms of doing a live stream. And again, with the opportunity and help from our staff at Digital Services, we'll be able to do a conference and get you guys your CEs as well. I do have to read a disclosure statement, and then I will tell you in detail how everyone is to receive their certificates. UI Health is approved as a provider of nursing continued professional development by the Ohio Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. The continuing education program for 5.16 hours is provided by the Department of Health and Social Work. The department is approved by the Social Work Continuing Education sponsored by the Illinois Department of Financial and Professional Regulation Continuing Education. No other conflict of interest have been identified by any of the planners or presenters of this activity. In regard to successful completion, and contact hours will be awarded accordingly. 5.16 hours of continuing nursing education will be awarded to participants who attend the entire duration of the activity, actively participate in the dialogue and discussion, complete the post-test with a score of 80% or greater, and complete and return the evaluation sent via email. Now, actively participate in dialogue and discussion with us live streaming on YouTube. I ask you to turn off your chat section unless you are going to ask a question. Samantha, as well as myself, are in the background on the live stream, so if a question is asked, we will ask the presenter and by all means interrupt and ask away. Don't have to wait until the very end of their presentation. The post-test. I don't want anyone to sweat. It's not like it's the SAT or the ACT. It's 7 generic questions just to make sure that you are in attendance and that the CEs are given out accordingly. So after today's presentations, tomorrow you will receive an email, a link. You will see it's a SurveyMonkey post-test. Fill out the post-test, send it back, we'll correct it, and once the corrections are done, if you have over 80%, we will send you another link with a SurveyMonkey for your evaluation, as well as you'll be able to print up your certificate at the end of the evaluation. Dietitians and techs, you will receive the certificate via email. Again, social workers and nurses will be able to print up their certificate. Everyone will be receiving 5.16 hours of continuing education. So, hopefully there's no kinks or problems that we'll have. Again, this is all new to us. We are probably going to run into some problems. Please bear with us. And I hope you enjoy the program. Please ask questions. Please get involved. And we'll go ahead and get, in between presenters, there will be like at least a 5-minute break to wipe down the area. We are going to practice the social distancing and sanitizing all the different areas and so forth. So in between speakers, go to the washroom, get a cup of coffee, a glass of water, and so forth, and you'll have ample time. So without further ado, we're going to start off our conference like we have many years past, and that's with an official welcome from Dr. Enrico Benedetti, head of the surgery department here at UI Health. And he's also going to talk and present about the State of the Union, the state of our address of our transplant program amid this pandemic. So at this time, I'd like to introduce Dr. Enrico Benedetti. Click on there to advance the slide.
Good morning and welcome to this unusual edition of our annual meeting. It's a lot more fun to see you in the room and interact with you directly, but we'll do the best under the circumstances. You can see on the slide Maria Lopez. She's a nurse that actually has been a pioneer in nursing for robotic surgery. Since when we actually acquired first system, which was in late 2000, Maria was a young nurse in 2001 and took on herself to actually perfect the essential support of nursing for robotic surgery. She was called Infermiera Robotica, because she's Latina, of course. And she has been an enthusiastic adopter of technology that has been the leader of our robotic nursing team for the last 20 years. She has been featured in international meetings. She has participated to our robotic surgery society, has been a model of professionality and a wonderful human being. Unfortunately, Maria got sick with the virus early on during the pandemic. And despite the best attempt from a local hospital, she actually succumbed to COVID-19 pneumonia. She has been greatly missed, and we'd like to dedicate to her memory this entire program. And I hope if she's up there, she can watch us and approve that. Goodbye, Maria. I decided to actually offer you a view of what happened during this COVID-19 pandemic to Transplant. Interestingly enough, when the pandemic started really going up in Chicago and the rest of the country in mid-March, there was some concern about what to do with surgery. In an area of the country like New York, where the pandemic really hit hard, a friend of mine at, for example, Columbia told me that within days, the entire hospital intensive care was overrun by COVID patients. So they actually used the majority of the operating room as ICU room. So Columbia had everything shut down except 3 rooms that they preserved for absolute emergency. So they stopped any form of elective surgery, including transplant, for a while, and concentrate only in emergency, life-threatening emergency. Mercifully, Chicago has not been affected as much. We had at that time about 1/10 of their case, and the system has been stressed but never broken. So we had a situation of serious threat, but not a catastrophe like New York. In this context, we actually choose to stop all the elective surgery, but preserve some surgery that, according to our judgment, as well as the opinion of the American College of Surgery, were important and should not be stopped. For example, we, of course, did not stop emergency surgery, like for acute appendicitis and the like. We did not stop cancer surgery. We didn't think it was fair for patients with cancer to wait. And we did not stop cadaver transplant surgery. We stopped in late March our living donor program, which reopened May 10th, but the cadaver program we never stopped. And this is in line with international and national opinion. The concept is patients on dialysis experience high mortality on the waiting list, and they may have once in a lifetime opportunity to be transplanted timely with a good cadaver organ. So we cannot deny them the opportunity. Even in New York, cadaver transplant has been carried out at decreased rate. Even in northern Italy, which was the part of Italy most affected by the pandemic, we actually had the opportunity to continue cadaver organ transplant, which we did. And we did with the usual dedication to our patient, trying to avoid particularly old recipients that are most at risk for COVID pneumonia and unfortunate outcome. But we continued. Now, what we did is actually quite interesting, and I'll be glad to show you some of the number in the next few minutes. In general, we had several challenges. For example, early on, we did not have any fast testing for our recipient or for the donor. We must thank a local company, Abbott, that did a fantastic job in providing, especially to Chicago Area Hospital, their fast testing, that if it's done correctly is a formidable tool which we validated internally. So after the first 2 weeks, we actually did all the cases testing donor and recipient. We were happy to notice that throughout the pandemic, now hopefully we are, for Chicago, at least the first wave at the end, we had no patient that was recently transplanted suffering of COVID. Sort of interesting. We had a total of nearly 40 patients, mostly over the year post-transplant, that were affected. And unfortunately, like in other centers, the mortality for transplant patients that got COVID is substantial. It's been estimated between 17 and 20%, which compare with the maybe 0.2, 0.4 in general population. So transplant patients being immunosuppressed suffer incredibly high mortality from COVID. I want you to know, as most of you work with dialysis patients, that the only group that had higher mortality was chronic renal failure patients on dialysis, that in many reports had a mortality of nearly 30%. So moving them from dialysis to transplant was actually beneficial even on that regard, especially since, for reasons still not fully understood, at least in our center, we did not see a lot of patients that develop COVID early on, as I stated. So this is slides that show you our volume throughout the year, for the fiscal year. Starting in July, you can tell that we had an average of about 25 cases. That include not only kidney, but also liver and pancreas. As you can see, starting from March, we did not decline. We had one of the few transplant centers that did not decline the volume, even though we halt for temporarily the living donor program for kidney and liver. So we did average 24, 24, 24. For example, in April we did 10 kidney, 7 kidney pancreas, and 7 liver. In May, more liver and kidney than pancreas. This is because although the donor supply declined, especially in March and April, we were able to actually get donors from outside the state, since many programs were reluctant to operate during the COVID pandemic. And if you look at our fiscal year 2020 volume of kidney divided in living donor and cadaver, of course, you can tell that in March we did 3, in April 0, in May we restart, but we compensate with a decent number of cadaver kidney. So I'm sort of pleased to share with you that we continue to actually provide our transplant services at very high volume despite the pandemic. The program has done about 200 kidney alone, without counting liver, kidney, and kidney pancreas. They give us another 30. So it's a substantial volume despite the pandemic, and probably, at least by the April count, the largest in the city of Chicago. So just to confirm to you that even in the most difficult situation, our team will continue to do its part to provide access to transplant to a disparity of population that are usually excluded. During the day, and this is just to complete, show you the liver and the kidney, you can tell that in April we peaked at 7 cases of kidney pancreas, and then in May we went to 0 because we exhausted our waiting list. There were so few centers doing pancreas that we got them all transplanted in April. Now we are rebuilding the list, and we have about 6-8 patients waiting, but we cleaned completely our list. In the process, we became one of the top 10 pancreas transplant program for volume in the nation. Last year we were number 8. I think this year we are number 5. So it's been an interesting run. There's been a lot of work from our coordinator, our transplant surgeon. Pretty much we did not take a break, as you can see. The program continued to serve a inner city population. The kidney program is mostly an African American based program. We do 55% of our case in African American, 30% in Hispanic, and the balance in Caucasian and Asian. We tend to take care of patients that nobody wants, as you know. And you will hear a lot about from other presenters. As you know, we are the leading center in the nation for robotic surgery for kidney transplant in the patients with IBMI that are typically refused by other centers. We are the center that does the patient with calcified vessel, typically refused by other centers. And some of my colleagues and partners will actually describe for you the technique that we use to achieve this result. But the surgical team could not work without a formidable support of pre-transplant nurse, post-transplant nurse, assistant, the schedule, administrative assistant, social worker, dietitian, psychosocial evaluation, nephrologist that are playing a very important role in our system. So we have truly a team, a large team led by a capable administrator that is currently Jamie Gaffari. We have a maintenance list team that ensure that we have the ready list nearly 85%, which is 20% greater than national average. So we don't want our patient to miss that opportunity that they are called. In summary, we are here to serve the inner city community of the city of Chicago. We are expanding in Illinois with a strong partnership with Rockford that will allow Rockford patients to be actually worked up locally under the supervision of a famous transplant surgeon, Dr. Bartlett, that is now on our staff for transplant. So we are in an interesting phase of our program where the expansion seems to be continuous, and we like to maintain the momentum. We thank you very much for choosing to connect with us today, and if there is any question, I will be happy to answer. Otherwise, I will oblige David taking a 5 minutes break to clean up. And I wish you, all of you, a safe time as we recover from this catastrophe. Please be prudent. Don't let the guard down in the last few weeks where the risk is present, because if you do a good job, hopefully we'll be safe for several months, and then we can get reorganized and ready to face any challenge. Thank you so much.
Thank you, Dr. Benedetti. Before we get our next speaker, again, we're going to have to do a wipe down and so forth. I have been getting emails that some people cannot log in to the YouTube site. There's been no restrictions put on the site, so if those people that are live streaming can get a hold of those that can't get on, it's been suggested that they try another browser. Firefox, MSN, Chrome, but there's nothing we can do at this juncture. So please try another browser. Also, too, people said that they are watching it live stream, but their name's not showing up in the chat stuff. That's fine. We're not checking attendance, via that way. You'll still get credit as long as you fill out the post-test and the evaluation. That'll be sent to you in the next couple of days. Okay, we are going to take a little break, wait for our next presenter, and wipe down this area. Okay, our next presenter is Alexandra Castells. She was a senior researcher for the UI Health transplant team, and now she's actually come on board and is now a living donor transplant nurse. So she is going to talk about a study that we talked about in the past, a GH study for patients that received their transplant. And now Dr. Benedetti wanted to do a study on patients that are actually on dialysis awaiting a transplant to see how that transposes to those patients. So at this time, I'd like to introduce to you Alexandra Castells.
Good morning, everyone on YouTube. So as Dave said, we are going to be talking about a study that I'm sure a lot of you have heard about if you've been around UIH for a while. It's a program we've been doing for a little over 6 years in general, and it's called Fit for Transplant, otherwise known as the GH Research Study. Like Dave said, I've been working with the study for about 6 years, and we also partner with a group called the GH Fit Lab, who conducts our exercise physiology and our muscle therapy itself. The PI for the study is Dr. Enrico Benedetti. So a little bit of background, we did start this study in kidney transplant patients, and as many of you know, kidney transplant is the preferred treatment for patients with end-stage renal disease. However, it doesn't fully address every facet of the disease. We've seen many of these patients still after transplant have a decrease in their physical function. They have an increased risk for cardiovascular disease. They have poor quality of life oftentimes, poor self-perceptions, and they often have difficulty pursuing and maintaining employment as well. So the study that we did was a 12-month randomized control trial, and it was in patients that had already had their transplant. We had 2 different groups in this study. The first group was the exercise rehab group, and for these patients, they underwent a 12-month personalized one-on-one physical training. The trainings were conducted 2 times a week for about an hour each session, and it was a mixture of full body trainings done in a way that would conserve their energy but still give them the maximum strength and improvements. We had 52 patients complete this study in that arm. The second group then was the standard care group, and this is our control group, and we had 28 patients complete that group. So some of the results of this study, we saw a significant increase over time between the groups in physical health, and this was reported by the patient how they felt in general. We also saw a significant improvement in their mental health compared to the 2 groups over time. We saw a significant difference over time between the groups in their physical function. Again, this was self-reported by the patients. And then most notably, we saw a significant increase between the groups over time in employment. So looking at patients that started unemployed for this program, over time, we had about a 50% increase in the patients that were on the exercise group versus about a 10% in the control group, which was quite interesting to see. So moving on to the dialysis study. Again, these patients still struggle, and they often have a high rate of muscle atrophy, lower physical function, and they have a high risk for cardiovascular complications. As the disease progresses, oftentimes so does this muscle and skeletal dysfunction, and this can lead to problems with mobility. They often feel like they're losing their independence. Depression is very common, and they are vulnerable for disease complications overall. The reduction in this cardiovascular and physical function and depression also have been associated with higher rates of mortality in this population. So we performed a pilot study about a year ago, and we had 11 patients in this study. This was just a 6-month trial. Again, they underwent this one-on-one personalized trainings for the muscle therapy, 2 days a week for 60 minutes each session. The purpose of this program for dialysis patients was to improve their physical function, their mental health, and reduce mortality, and overall just kind of help prepare them for a successful kidney transplant and recovery. So some of the results from this pilot study, we saw a significant increase over time in their self-reported physical function. We saw a significant increase over time in the short performance battery score, which is a measure that's often used to assess kind of their overall physical function and frailty. So the higher the score, the better. And it's a combination of looking at their balance, their walking abilities, and their endurance via sit-to-stand assessments. We saw a significant decrease in their level of pain interference as well, and a significant increase in their energy levels and a decrease in their fatigue. And in patients on dialysis, this is a very important measure to look at because oftentimes they're very fatigued, they have very low energy because they are doing dialysis 3 times a week, and it takes a toll on the body. We saw a significant decrease in depression in these patients as well, and a significant increase in just their general health. And this is a combination of both their mental and physical health. So we have a patient testimonial. It's great to see all of the data itself, and it's very promising, but it's also very impactful to see it on a more personal level. So we'll show this.
I come from a family where it's more people who are diabetic than non-diabetic.
I'm beginning to see even people young as me, even younger, coming in for dialysis.
Like my mother's diabetic, my dad's diabetic, my sister's diabetic, my brother's diabetic.
Maybe because when we were young growing up, people didn't recognize what the killer was. We just said it was sugar.
And by both my parents being diabetics, I knew it was gonna come my way.
Well, no, it's beyond just sugar now. It's going to kidney failure.
I had gradual kidney failure, but my kidneys truly failed where I had to go on dialysis in 2010. Yes, I knew that I had to depend on this machine for life, which was one thing. But the other thing is to sit in the center where you're sitting with a lot of people all hooked up to machines in various stages of, some people were young, some people were somewhat energetic, some people were old, some people could not move, some people had to be brought in by ambulance and they would be next to you. And that's somewhat depressing. I was called at home and asked to be in this particular program. And at first, I was really apprehensive about it. When I first saw the machinery here, I was like, oh no, they picked the wrong person. There's no way on God's earth that I'm going to be able to navigate my way with the machinery in here. It's just so intimidating. When you on dialysis for as long as I was, you don't realize how your muscles are slowly going down. My first week, when I started doing the program, I felt like, will I last? And I found out I didn't hurt, I didn't feel tired, I didn't feel overworked, I didn't feel like a failure. I leave here and I say, man, I wish my daughter could come here, because they're diabetics as well, And I said, man, if they could get started early, then maybe they could avoid some of what, I went through. The GH program that I went to strengthened me so much that I was allowed to get a kidney. I had more than one surgery, and I still was able to get up out of the bed by myself.
It's really like a miracle. It really is. To be able to move, get up, go in the bathroom. Well, I know it's the kidney, but I also know that it's the training that I had. You know what I mean? So they really just work together.
And when Greg told me, you're gonna walk without the walker, my mind said, no, that ain't gonna happen. I know, he may think I'm gonna do it, but I know I'm not gonna do it. And then one day he said, turn the walker loose. And I just started walking. And it was like, I just couldn't believe it. Sometimes I wish when I see other people who was in the same state that I was in, I wish they could have the same experience, that they could be able to rehabilitate their muscle, that they can improve their life by getting a kidney. I had great family support, from my husband, who would come to see me and write in, and my daughters who always would bring me to the sessions. Now I could enjoy myself. I could enjoy my life. And I just know that it's through that program.
Kidney failure has taken my left eyesight. In 2014, I had a cerebral vascular accident, which is a stroke. I had a stroke. I now have poor use of my left leg, so I have to. I'm tied to a walker now, and it got to a point I can't hardly walk anymore. I have to now sit in my walker and use like a wheelchair 90% of the time. When you've been on dialysis for 9 years, and every time you wake up, you feel something else is breaking down in your body. For example, the eyesight, and then the stroke, and then this happens and that happens. No matter what the case is, you feel that you're dying, physically and mentally. Mentally speaking, because you look at the person that you were at one point, and now the person that you're not. Physically, because you see the physical deterioration of your limbs, of your body. As I went through the assessments and so forth, I felt a renewed hope. And then they said, we're going to get you a kidney. Once we get you walking again, we're going to put you back. So I feel a renewed hope. I feel that there is light at the end of the tunnel. I think that it was just God's way of saying, it's not your time yet, but you've been through enough. Now it's your time. You've been through enough. I look back on it now and I see that I'm not even the same person I was 6 months ago. I'm able to walk on 2 feet with my cane. As before, I was running around in a walker, and now not to have any pain in my legs, no pain in my ankles or feet, or pain in my thighs, no pain whatsoever. It's been a miracle. I'm able to get on the machines, able to do different types of exercises now that I haven't been able to do before. Even be able to stand up and sit down, stand up and sit down multiple times is a shocking, and I enjoy it, I feel I had so much more energy. I felt so much more excited. I was like, I feel good, I can do this, But no, it was very exciting to see my body do that. I wasn't able to do that before. Able to just stand up on my own. My mental state is so much more healthier now than in times past. I'm not sad. I don't feel everything's gloom and doom. What was me feeling? I care about myself now. I care about others around me. I love life. I want to smell the flowers. I want to experience things. I can't wait to take my kids to Disney World now and have fun with them hopefully one day without being on dialysis. I'll be stuck in the machine. But at least I got freedom of movement now, so I can take them different places now. I feel that my life it's taken off. I was getting healthier. My body was responding to the muscle therapy. I was able to walk. My numbers were looking good. Now there is light at the end of the tunnel. I'm on the transplant list now. And any day now, in fact, I can be sitting here right now while I'm doing this interview, I get a call. Hey, come on over now and get the kidney. April 3rd, 2019, I just received 2 kidneys. And I'm so happy. Give to the GH Research Muscle Therapy Program. They are miracle workers.
Okay. So, since we completed the dialysis pilot study, we are now doing the extended version of this study. And this is going to be a 12-month randomized control trial, similar to the kidney patients that we did in the beginning. The first group is the exercise group, and they are going to be doing, again, this 2 days a week, 1 hour each session. And it's going to be, again, this full body, one-on-one personal training. Muscle therapy. So the program is meant to help reduce the pain in these patients, increase their strength, and overall increase their physical function, quality of life, without feeling very tired out afterwards. The second group then is the control group, which is just no intervention, but just their normal standard care. Both groups will undergo data collection, both 3 times actually, at baseline before starting, 6 months in, which is halfway, and then at the very end at 12 months. So potential patients for this study, these patients have to be on dialysis, English speaking, clinically debilitated, so weak, easily fatigued, maybe issues with mobility, no contraindications to exercise, and they must be able to come to UIC 2 times a week for these trainings. So patients that live closer generally are better candidates for this study. We do all of our testing and our training down here at UIC, 1640 West Roosevelt. Parking is available for the patients. And currently, we desire to have 150 patients in this study in total. We've screened and talked to over 140. And enrolled to date, we have 30 patients. So it is a study that's a little bit more difficult to enroll, understandably because these patients, their week is filled with dialysis and other doctor's appointments. But we are still currently enrolling in the study as well. No? Okay, thanks.
Okay, again, we'll take a short break, a 5 to 10 minute break, and do a wipe down and wait for our next presenter. Again, we are getting a lot of questions asked regarding the CEs and the login. People said they have registered but never got the email with the link and so forth. If you got any email regarding the link, the disclosure statement, the agenda, and directions about the CEs, you are registered, so don't worry. You will get the post-test and evaluation to fill out, and you will get credit for all the hours, okay?
I just want to see the battery life. Okay, good.
You need to log back in. It logged you out because I think we were.
Oh, that's okay. Awesome. All right, we are going to go to another presentation. Oh, here we go again. Is she here? Okay, we're back. Unfortunately, our next presenter, Dr. Jerry, is running late in clinic, so we are going to skip ahead. And our next presenter actually is going to be myself and Samantha Mock. And we're going to talk to you about optimizing the referrals to UI Health, which of late, during this pandemic, a lot of you have been doing a great job sending us the referrals and getting people appointments and getting worked up and listed. But Samantha's going to go into greater detail. And at this point, Samantha, come on up. And this is Samantha Mock, who is our other transplant outreach coordinator.
Hi everyone, my name is Samantha Mock, like Dave said, and I am one half of the outreach team here at UIC. And I'll be giving this presentation about the optimization of transplant referrals to UI Health, UIC, on behalf of both of us. Dave has a slide at the end that he'll go into as well. Here, I just want to bring to your attention our address, and our main phone number is here on the slide. At the end, I'll have both of our direct contact information, our direct phone numbers, and our direct email addresses, so you can contact us with all those referrals that you want to give us. So there are three things that I would like to make sure that you take away from this presentation. The first is simply how to make an effective transplant referral. In the presentation, I'm going to go over all of the supportive documentation that you all can help us support the patient in supplying to us to help make sure that their transplant workup goes as smoothly as possible. I'm going to also talk about the high-risk groups and the transplant specializations that we specialize in here at UIC, and also who to contact if you have questions about a referral. And that can be a referral that you have not made yet. You want to know if it's an appropriate referral, or it can be a referral that you want to make that you have already made, and you want to follow up on that referral. So I want to take this opportunity just to brag a little bit about our program. I love to brag. Who doesn't? In 2019, we did 217 kidney transplants here at UIC. And that number is significant for a lot of reasons, but I'm going to touch on two. The first reason that's significant is because it's a huge number. That is just a phenomenal number of transplants that any center can do. And the second reason is that is the most kidney transplants that any center did that year in the whole Chicagoland area. So that is something that we are extremely proud of, and it's something that we want to keep the momentum going on. The second thing is that we did 93 living donor transplants as well last year. So that number is significant for a lot of reasons, but I want to talk about two of those reasons. One is it's a huge number again. The second one is that 93 living donor transplants showcases just how much we prioritize and streamline our living donor transplants at our center. That's something that we're extremely proud of. So when I was writing this presentation about 3 weeks or so, just a way to tell you how busy we are and how large our center is, we had about 560 patients listed at that time. That was 3 weeks ago. It's probably more than that now. So we are an extremely busy center. And not only are we extremely busy, but we're extremely established. In 2018, we celebrated our 50-year anniversary for our program. So we are a very busy, established program here in the Chicagoland area. Here are a couple of reasons that we stand out as a transplant center. The first one is probably the most well-known. It's the fact that we transplant higher BMI patients, and not only do we do that, but we specialize in transplanting patients with higher BMIs. We're known for that locally, but not only locally, we're definitely known for that nationally as well. We also have protocols to transplant HIV-positive patients and hepatitis C-positive patients. And one thing that I recently learned about the hepatitis C protocols is that not only can we transplant a patient who is hepatitis C positive with a hepatitis C positive kidney, but we also have protocols in place where we can transplant a hepatitis C negative recipient with a hepatitis C positive kidney. Of course, we're not going to do that willy-nilly. That requires patient consent and making sure that we're doing the right thing. But that's a big reason that we stand out, and it's one of these high-risk groups that we specialize in. Dr. Hajiri is going to go into more about the ABO incompatible protocols that we do, but we specialize in transplanting ABO incompatible donors. So if you walk into UIC with a donor who's gung-ho, but unfortunately they're not able to donate, we have medical protocols, and we also have a very viable swap program that we can initiate those patients into. This is one that I'm really proud of. We have a very close relationship with the Illinois Transplant Fund. We have 3 financial coordinators here, one of which specializes in making sure that those AKF patients, those American Kidney Fund patients in the dialysis world, are able to get the cleared by the cleared by the Illinois Transplant Fund prior to them even walking into the door. So that's one, just as a social worker, that I'm extremely proud of, because I think it shows our commitment to our community. UIC is dedicated to transplanting anybody who wants to be transplanted and anybody who shows a compliance enough to be transplanted. Another, and this is the last, again, this list of high-risk groups isn't exhaustive, but it is, I hope, comprehensive, is the medication assistance program that we offer here. The medication assistance program, I'll talk about two reasons that I think that it's important. The first one, on the pre-transplant side, is it can help support those patients who are maybe on the cusp about being a good, viable transplant candidate. The medication assistance program is a pharmacy. It's staffed by pharmacy technicians, it's staffed by pharmacists, and I believe there's even a social worker in there as well, who can help us optimize the candidacy for a transplant patient. So for instance, if we have a patient that comes to us and is interviewed by any of our team members, we can, and it's found maybe during those interviews that maybe the patient is not taking their medications correctly, and we just don't really understand why. We may dig up reasons that there might be literacy issues, there might be issues about, them. I've had a patient before who was taking who was told to take their medications twice a day. So we took it at 3 o'clock and at 4 o'clock. Well, that's maybe not necessarily the right way to do that. So we can figure out those issues on the pre-transplant end, help support that patient in making them a good candidate, and then getting them listed and making them a successful transplant recipient. So on the other side, on the post side, we can use the medication assistance program to support patients who maybe have some financial issues, patients who, Illinois public aid is perfect all the time. That's a joke. We all know that it's not perfect all the time. But, what if the patient loses their Illinois public aid for whatever reason and they just need some help in the interim? Well, the medication assistance program can help with those patients as well. So before I get into the meat of the presentation, I do just want to talk about what Dave and I do. We are responsible for making sure that our community knows that we're here for them, and making sure that our community understands the services that are offered to our community. So we do that in a few different ways. We do that by attending the National Kidney Foundation, or the National Kidney Fund Conference. So Dave has been a presence at that conference for many, many years. He's shaking his head yes to me. And I think that conference is really important, because not only does it reach the patient, but there are lots of patient families who attend the conference. And I think that is really important to do. Being sick, having a chronic illness, affects the whole family, not just the patient. Pre-pandemic, Dave and I were hosting dinners to dialysis centers in the greater Chicagoland area once a month. So this is kind of different than the National Kidney Fund Conference, because that one focused on patients. The dinners focused on reaching the dialysis centers and the professionals who work there, and making sure they understand the services that we offer the community, and the services that can help assist all of the patients, as many patients as we can. At those dinners, we usually have a surgeon, Dr. Almario, usually, if not always, speaks at those dinners, and he does a really good job, because he breaks down the surgical process to a non-physician group, and it's really easy to understand and very clear. But we also have various other presenters. Social work presents there, the living donor nurses. Many people can present there, and you guys can get a good understanding of what we offer there. The symposium is self-explanatory. Thank you for coming. We have been doing this for many years. I've been on both sides of it, presenter as well as an attendee now. Referrals, I just wanted to talk about just a second, just touch on the fact that we can get referrals in many different ways. We can get them electronically, we can get them telephonically, but the most common way I think that we get the referrals is just doing lobby days. So Dave and I love going out to dialysis centers and spending the day or 2 days there, depending on how many shifts you have, and making sure that we're able to meet the patients face to face, making sure that we're able to meet the social workers and make those connections face to face. But not only that, not only giving the patients that education right then and there, but also we are available to give you all education in your center. We can do a presentation about our program so you all know what we offer. So when we're at the lobby days, this is one question that I started getting a lot, is the dialysis social worker would say, I was thinking about referring this patient, but I don't know if this is a really good patient to refer. Well, you know what, that's a really easy question. I would say if you have a patient who's interested in transplant, refer them. We wouldn't put it on you all to try to tease through candidacy issues or anything like that. Refer them, and we will figure that out, for ourselves. We welcome all referrals. That being said, we do have a list of contraindications. I think it's probably the rule that every transplant center has a policy on contraindications. I looked at our policy recently, and our policy has about 7 contraindications. Most of those contraindications are medical. So the bottom line was pretty much whether or not whatever the patient had going on, their life expectancy was going to be severely compromised, of course, outside of their kidney failure. So if the patient had an active cancer, of course, they're not going to be a good transplant candidate right now. So that list, actually, we can, and that policy per individual request, we can give to you all, so you know what our candidacy and exclusion criteria is about. I wanted to talk about, so I'll go in to talk about the path of the transplant referral. So first, the graft failure is here, the graft failure committee is here, but I'm going to talk about the path of the referral right here. So if we get a referral and we find out that the patient has had a kidney transplant in the past, not another type of transplant, not liver, not pancreas, but if they had a kidney transplant in the past, then they will need to be cleared by the graft failure committee first. That committee is charged with making sure that we just don't give away kidneys inappropriately. So there are a few different kinds of patients. If that patient comes and they've had a transplant in the past, and we see that transplant lasted 20 years and it was really clear that kidney just burnt out and the patient just needed another one, then we would likely just put them ahead and push them ahead through the ordinary referral process. But, we could have a patient who's referred to us where their kidney only lasted 1.5 years, let's say, and it was well documented that patient just stopped taking their medication. Well, not to say that patient is just going to be, excluded from our program forever, but that's something that we would have to get to the bottom line of. Did they have an active psychosis? What happened? Did they lose their job? Is it something that can be rectified? We'd have to figure all of that out. So after the appropriate patients go through the graft failure committee, we will get the registration. When the registration is received, the patient will get an appointment within about 2 weeks. So that's not to say that their appointment will be in 2 weeks, but they'll get their appointment date in about 2 weeks' time. Financial clearance, ITF clearance, AKF clearance will be obtained simultaneously, and then they'll come to the initial appointment. And I'll talk a little bit about the initial appointment in subsequent slides. The patient will go to their specialist appointments, and those specialist appointments could be different, based on the type of patient that we're talking about. I may need to get endo clearance, you may not, but you'll receive all of the specialist appointments, a list of those via mail. After the appointments are done, the initial appointment, the specialists, the case will be reviewed at a listing meeting that we have once a week, and at that meeting a decision will be made to list or not to list. And I'm going to get into the presentation now because that decision we hope will be made within about 30 to 60 days. So this is how to optimize. This is how you all can, as dialysis staff members, can help us optimize the transplant referral. So let's pretend that you are a dialysis social worker and you're sitting down with your new patient that you're just meeting, right, for the first time, and that patient says that they are interested in a transplant. Well, there are some steps that the dialysis center, can, support us in helping the patient do right then and there. If it's warranted, a mammogram, pap smear, dental clearance, colonoscopies. I mean, these are things that aren't going to hurt the patient. These are things that the patient should probably keep updated anyway, and it will definitely help to expedite the workup process. I had a stint where I worked as a dialysis social worker for a little while, and where I worked, the history and physical was part of the patient record in the dialysis unit. So it would help us tremendously if we could just get a copy of that history and physical, because you probably have an updated copy there. During the initial appointment, the patient will have an interview with the pharmacist and the social worker and physicians, and all of us are charged with trying to figure out whether or not, obviously, this is a viable candidate for transplant. And part of the way we do that is we try to assess medication adherence. So we would encourage you all to make sure that the patient help us encourage the patient to make sure that they have an updated medication list and bring their bottles as well to that first appointment. And these kind of go hand in hand. If it's make sure that your patient has a primary care physician. Again, that's not something that's going to hurt the patient. I, for one, think that everybody should have a primary care physician and have a relationship with them. But that relationship will also help us in getting referrals if the patient has an HMO. And we'll also need the 2728. That's usually pretty easy to get. So I talked a little bit about the insurance and needing the HMO referrals. The Illinois Transplant Fund relationship that we have, again, one of our 3 financial coordinators, usually it's Alicia, who does speak Spanish, will help those patients who are on getting assistance through the American Kidney Fund for their primary insurance. Usually it's off of the exchange, but Alicia can help those patients apply for the Illinois Transplant Fund and make sure that there's not going to be any interruption in insurance coverage, after that the AKF funding expires. As we all know, the AKF funding doesn't go on forever, especially after you're transplanted. So also, what you all can help us do is encourage the patient simultaneously while we're encouraging the patient. Again, I hope it's not sounding like that I'm putting all of this on you. I don't mean to do that. I'm just asking you all to help us support the patient by making sure that they know what to expect and making sure that they know what to expect when they come in for those initial appointments. But if the patient had a recent hospitalization, they can give us the discharge summary. If they have any other specialty consults that they can go ahead and start getting the records for, because I think a big holdup in the transplant workup process is just obtaining records from outside institutions. So you can help the patient, get those records as quickly as possible. And again, just if you can help us encourage the patient to advocate for themselves due to cultural differences, due to language barriers, due to a whole bunch of reasons, due to just getting sick all of a sudden and then having this institution around you, this healthcare institution around you that you didn't have before, can really intimidate patients. So if you can help the patient by encouraging them to advocate for themselves. If they have a question, make sure that they are comfortable with reaching out to us. So the nurse coordinator is it's definitely the person who is going to streamline all of the workup for the patient. So if you, as a dialysis professional or the patient at any point in time after that initial appointment has a question about the patient's workup, then I would encourage you to ask the patient, who is your nurse coordinator? They were given that information via mail. They were given that information on that first initial visit. So that is your point person. If if your medical director, if anyone has any questions at any point in time about candidacy, illicit drug use, weight, any medical contraindications about a patient that you haven't referred yet, you can always contact Dave or myself. If we don't know the answer, we have our physicians on speed dial, and we can usually get an answer really quickly. Another thing that we can do for you is just to make sure that you all have a list of the inactive, declined, or active patients who are listed here at UIC. If you haven't already, Dave and I can get you a list of those patients for you. And as many times as I went over this presentation, I always thought to myself I should put this one first, giving us updated contact information. So in the age of cell phones, in the age of moving a lot, especially when you come down with a chronic illness, your life can just change in so many different ways. But if we don't have your contact information, we can't list you, and we definitely can't call you in if we get an organ for you. So please encourage the patients to make sure that if they change their their contact information, to make sure that they're updating that on our end as well. So like I said before, I wanted to talk about the initial appointment really quick before I wrap up, because I think that that's really important. When I was a dialysis social worker, I really wanted to make sure that the patients were prepared for that initial appointment. Number one, it's a long day. You can tell them, as we already do, in our communication via mail with them, that they're going to be here all day. So if they need to bring food, bring food. If they need to bring money for parking, do that. We can validate parking, but it's not free. It's still about $6 or $7 at our clinic. If they want to bring money for food, they need to do that as well. So they'll get graft failure clearance before they even step in to see us that initial visit. They will get labs drawn. This is an important one, I think, that you all can help support our patients with as well, for a couple of reasons. One, it's a lot of blood. I always joke that we're like vampires, and we take upwards of about 13 tubes that first visit. But also, if you have a patient who does not like needles, I remember a lot of patients would go to PD for that reason, because they didn't like needles. Make sure that they understand that we are going to not only use needles on that initial visit, but transplant, you're going to always get stuck with needles. At that visit, the patient will meet the nurse coordinator, like I said, who is a very important person in streamlining this whole process. The dietitian, the social worker, the financial counselor, pharmacist, and one of the physicians that first visit, either the nephrologist or the transplant surgeon. So next steps on the path is the fact that the patient will be mailed a list of appointments, cardiology, other appointments. Again, the results will be presented at the listing meeting, where a decision to list or not to list will be discussed and determined. And by the way, the patients, I believe, usually will get a phone call from their coordinator about whether or not they're listed. But the hard, true way is is the fact that they'll get a letter in the mail saying when they got listed, the exact date and everything. And also at that meeting, usually there's a date set for the living donor surgery to take place. And like I said, a letter will be mailed to the patient regarding the decision. So to summarize really quick, and after this, Dave has one slide that he wants to go over. The referrals are multifaceted, and there are several steps. It can take, I've seen, inappropriately so, I think. I've seen transplant workups last a year. We really don't want that to happen. We want to make it last, 30 to 60 days maximum. The nurse coordinator is the one who streamlines the process. And also, like I talked about, UIC specializes in transplanting high-risk groups, high BMIs, ABO incompatible patients with their donors, and other groups. So I will go ahead and turn on to my coworker, Dave.
Okay. Thank you, Samantha. She did the bulk of the work on this presentation. I'm actually going to just talk about this one particular slide. A lot of the staff in services that I've done at the various dialysis centers, as well as previous conferences, I always talked about the triangular situation regarding all parties involved in transplant: the patient, the dialysis unit, and the transplant center. And communication leads to the best outcomes for a transplant. When everyone is on board, everyone knows what's going on, transplants seem to run smoothly and the outcomes are very good. When it's one person or one segment that is not aware of what's going on, that's when the problems developed. So an example is if a patient moves, a patient dies, a patient is hospitalized, insurance changes, and the only ones that know of the changes is the patient and the dialysis unit, and then when it comes to a kidney becoming available for them and the dialysis center is not aware of those changes, then it kind of puts a roadblock into the transplant, and there's a possibility that the patient might not be able to receive that kidney because of a change of insurance, or the patient is hospitalized or recently had an infection and needs to be updated, or they had a cardiac issue. So it's very, very vital that everyone is on the same page, that we communicate. From the transplant's perspective, I know we're not perfect, and there have been times that we get a call, Samantha and I will get a call from a dialysis unit, from a social worker or clinical manager, saying that patient John Smith just received a letter saying that he's no longer on the transplant list, but was never told and was never given a reason. We are trying to work on better communication skills and talking to the dialysis units, the nephrologist, as well as the patients themselves. But it works, both ways. So if you are aware of a patient that is having problems at home, has social, doesn't have family support, you think maybe they're starting to have a drug history, they have some kind of psychological issue, that you feel that that needs to be warned to follow up or update them, please contact the transplant center. Another responsibility, as Samantha mentioned earlier, we act as not only educators in outreach, but liaisons. We're the go-between. So if you try to reach out to the transplant nurse or the transplant center in general and can't get through or can't get a response, please, please, please get a hold of Samantha or myself, and we'll definitely get you to the right person or get an answer for you. So if everyone stays above the level and is aware of what's going on, again, transplant will go a lot smoother for the patients. That is all our information. Contact information for Samantha as well as myself. I will be happy to give you my work cell phone number too, which is 312-636-2106. And I know during this pandemic, obviously we can't do lobby days, but soon as we get to phase 5, or your corporate hierarchy decides that it's okay for Samantha and myself to come in and do lobby days, we are dying to get out to talk to your patients, as well as talking to your staff, and looking forward to doing dinner talks as well. So that is all I have at this time. I believe, Samantha, we had some questions earlier that I answered, and we'll leave it at that. Thank you, and we'll now set up for our next speaker. Okay, for our next presenter, Dr. Zahara Hajari is our transplant nephrologist, and she is going to talk about something that we kind of specialize here. We're one of the few transplant centers that do what she's going to be talking about, and that's ABO incompatibility kidney transplant. So at this time, I'd like to introduce to you Dr. Hajari.
I'm Zahara Hajiri. I'm one of the transplant nephrologists here at UIC. I've been here for the past 6 years. I'm going to be talking about ABO incompatible kidney transplants and our experience here at UIC. I have no conflict of interest to disclose during this presentation. Before I start, we all know what the benefits of kidney transplants are. In general, especially in diabetics, kidney transplant increased the life expectancy by a mean of 17 years compared to 8 years with dialysis alone. In regards to life quality, we all know the majority of the patients have improved life quality with kidney transplant, with them being able, if they're young, have a family, if they're older, travel and be able to get through their life, get a job. In regards to the cost, believe it or not, 1972 Social Security Amendment guaranteed access to the care for those with end-stage renal disease, with a cost for ESRD estimated by $75 million per year. The cost of kidney transplant is about $110,000 in the first year, and then average about $20,000 to $20,000 per year thereafter. Now, even though we know that kidney transplant provides the best quality of life, improves mortality, and reduces the cost, we still have problems. We still have a problem with supply and demand. There is a very long wait time for a kidney transplant in the U.S. Here, briefly, it's a figure from 1990 until 2010, where the number of the patients on the waiting list has exploded, with the gap between the number of transplants and the number waitlisted is also increasing. We have a problem with supply and demand. We have a problem with the supply of organs. So what can we do? The possible solutions, as I usually say for all our organs, there are two types of kidney transplants. There are the transplants that come in from living donors, and there are the ones that come in from deceased donors. In general, living donors' kidney transplants provide the longer longevity, the best longevity for recipients. There is a colleague who used to tell me when I was a fellow, the worst kidney, the worst quality, the kidney that comes in from the oldest living donor will provide better outcomes than the best kidney on the cadaveric list. So what can we do? First of all, try to promote living donation, which is a separate talk. It's a long talk on its own. But for deceased donors, we can reduce discard rates. We can use more kidneys that used to be discarded in the past, such as baby kidneys on blocks. Dual kidney transplants, so those are the kidneys that come in from patients who just passed away. There is a lot of scarring in the kidney, there is a lot of fibrosis, and a single kidney is discarded, so we can take both kidneys. KPD programs, if we have a pair, a living donor and a recipient who are not a match, can we swap them with other pairs? That's what KPD programs are. Last but not least is ABO-incompatible transplantation, which if a KPD program is not an answer, or this pair is not finding another pair that they can swap with, we can provide an ABO-incompatible transplant. Now, if we go back in time, first attempts for kidney transplants at all, we're not talking about ABO-incompatible, we're talking about first attempts for transplants. In 1933, it was the first transplant that was performed by Yuri Voronoi. It was the first deceased donor kidney transplant. Patient died after 2 days. In 1933, there was there's no cross match, there was no match. We didn't know much about the immunological part of the transplant. Now, in 1954, Dr. Joan Merrill, who's considered the father of nephrology and transplantation, had a referral from a colleague for these twins here at the bottom. They were identical twins, and one of them had a glomerular disorder that caused kidney failure. And then even dialysis was not very much available for everyone. So Dr. Merrill had the idea that the challenge in kidney transplant is not because of the surgical technicalities and the challenges. The challenge in transplantation is more immunological, is more tissue acceptance. So he was looking for an opportunity to have these two, to have a transplant that may succeed. So he had these two identical twins, and the first thing that he did actually to make sure that those twins are identical twins, he actually fingerprinted them in the police station. He made sure that they have identical fingerprints. When that was the case, he wasn't even satisfied. He had a skin graft transplant from the donor to the recipient to see if the skin graft will take. And after the skin graft took and it succeeded, he referred them to Dr. Joseph Murray, who is the transplant surgeon, who is actually a plastic surgeon, who performed the surgery. Now, I can barely identify the difference between both, but this is Richard and Ronald Herrick. Richard is the recipient who lived for 8 more years post-transplant, and Ronald lived 56 more years post-transplant. So it's a neat case and a neat story that tells you about the history of transplantation, the first successful transplant. Now, ABO basics. I know ABO incompatibility and ABO incompatible kidney transplant, there is a lot of immunology in there, but I would like to talk about the basics a little bit so that when we talk about the challenges, you would understand the challenges. Now, AB antigens, those are antigens like a carbohydrate, glycoside-based antigens that are on the surface of cells. They're mainly on red cells, and that's why this is what we look for blood type compatibility. We'll look for A and B. So there is a blood group A, in which we have antigen A on the surface. We have blood group B, in which we have antigen B on surface. And blood group AB, we have both on the surface of cells. Blood group O has none. Blood group O is a naked red cell. This is how I think of it. Now, antibodies you should have, or the antibodies that are present, if present, they'll be present against the antigen that is on the red cell. So if you have a blood type A, you may have an anti-B. If you have a blood type B, you'll have an anti-A. If you have both, you'll have none, no antibodies. If you're a blood type O, you may have both antibodies, anti-A and anti-B. In general, the prevalence for the blood types in regards to the ABO, blood type O, is present in about 45% of the Caucasians in the United States, about 50% African Americans, blood type A, 40% Caucasians, about 27% in African Americans, B, 11 and 20, AB is the least common. In general, blood type O is a universal donor. This is the donor that may give to any blood type, because the cell is naked. You won't have any antigen on the surface to which the antibody will attack. Blood type AB is a universal recipient because they will never have any antibodies against any antigen. Now, we're talking about red cells. What does that have to do with the kidney? Some of you may ask, so those are red cells, we don't transplant red cells, what does that have to do with the kidney? Those antigens are also present in the lining of the endothelium in the kidney, so the blood vessels in the kidney have those antigens, either the blood vessels in the glomeruli, in the peritubular capillaries, so those antigens are present throughout the kidney. So if you have a mismatch with antibodies in regards to those antigens, you may develop a rejection. David, are we doing questions at the end or during? Okay, thank you. Okay, back to basics. So I try to simplify the reaction as much as I can. So this is the typical immune reaction that occurs for a mismatched antigen. So what would happen is you have the cell, which is, I call it antigen-presenting cell or macrophage. This is a cell that engulfs and eats up any antigen, anything that does not belong to you, that is abnormal to you, that is foreign. It'll eat it up, and then it'll present it on its surface. It'll present it to a variety of cells, T cells, B cells that would become plasma cells. Those are the B cells and the plasma cells. Those are the cells that produce antibodies. And those antibodies would be produced and attack whatever is abnormal. So in here, if this is the transplanted kidney, those are the antigens where those were abnormal, the AB antigens. Antibodies will bind and will produce a series of immunological reaction. So those are basics. So in other words, we have the antigens, blood antigens that are present in the kidney. If there is an antibody against that antigen, then you will produce these antibodies against those antigens, and you will have an immunological reaction and tissue destruction. So based on that, if you had antibodies against the kidney or any type of antigens in the kidney, in the past, an ABO incompatible transplant used to be an absolute contraindication for a kidney transplant. Anyone who's ABO incompatible, if they receive a kidney with antibodies, the kidney at the time of revascularization will become pink and then blue and shrivel up, because there is a hyperacute reaction, and this is what we call a hyperacute rejection. So how did we know this and what happened? So in 1955, this is the first ABO incompatible transplant, where a type B donor went to a type O recipient, and there was antibodies in the recipient. The moment the kidney got perfused, it just failed instantaneously. Later on, same year, a different physician performed 10 ABO incompatible transplants. 8 of them failed within days. So this is in 1955. We didn't know much. In 1982 until 1987, there were a series of papers, case studies in which we understood that there are antibodies. So Alexander, one of the physicians, finally succeeded. What he did is that, why don't I wash out these antibodies? So he actually freezed those antibodies for 23 transplants. There was 75% graft survival of 1 year. So after that, we started understanding, hey, there are little buggers in the blood that are moving around that may be attacking the kidney. What if we remove them? So Alexander succeeded. So based on that, what are the concepts of kidney transplantation in a sensitized or ABO incompatible patient? So we either have antibodies against any tissue antigen that we know, or a blood type antigen such as AB. So one of the concepts is removing the antibodies. So what if we remove the antibodies to a level where they're no longer detectable? So if I go back to the schematic over here, so I'm intervening here. So at this point, remember there are multiple points before the antibody presence. So what if I remove the antibody here and then blast them with a lot of immunosuppression so that I will get rid of these plasma cells or B cells so that I would force the immune system to accept this kidney? So that's one path. The other pathway is, as I mentioned, suppress further antibody production and then monitor the patient for their graft function. So this is the concept of desensitizing a person, removing the antibody, give them a lot of immunosuppression to suppress the cells that are producing the antibody and monitor them closely throughout. So what about desensitization for ABO incompatible kidney transplant? There are 4 main concepts or 4 main ways. The most common way that the majority of the programs use is what we call plasmapheresis. We connect the patient to a machine. It's similar to dialysis machine, by which the blood goes through that machine and we pherese out those antibodies. We get rid of those antibodies. The other step is giving them IVIG. We give a hyperimmune serum. So there is a highly concentrated immunoglobulin in that solution that actually attacks a lot of either the immune cells or the antibodies, or it also, what it does, it replaces the antibodies that we're removing by plasmapheresis. What we can do also, what if we remove those plasma cells or B lymphocytes? So this used to be done in the past, where the surgeons either do a splenectomy, so they remove the larger pool of plasma cells that is present, or we give an anti-CD20 antibody, which is rituximab. It does the same thing. It gets rid of those plasma cells. Or what if I kept this cell line, and I kept the plasma cell, and I kept the production of the antibodies, but I paralyzed the effect of the antibodies. So I gave a drug that, after the antibody binds to the antigen, it's not causing anything. And this is the concept of the eculizumab, or it's a complement inhibiting pathway drug. So again, back to this figure, you have the antigen-presenting cells, the immune cells with the antibody production, and then the binding to the organ. So steroids typically affect this line. Rituximab, the B cells. Bortezomib is another drug that we use for desensitization. Plasmapheresis gets rid of the antibodies, and IVIG does everything. Eculizumab paralyzes the effect of the antibodies. So, in regards to plasmapheresis or antibody depletion, so the strategies are plasmapheresis, in which we remove plasma proteins, including immunoglobulins. This is the most common, and this is the preferred antibody removal in the United States. Membrane separation, it only removes a specific fraction of the plasma proteins, which are immunoglobulins. And this is common in Japan. Unselective or selective immunoadsorption, it's selective removal of specific antibodies, and this is, performed by the addition of a specific filter to the plasmapheresis machine, and this is very common in Europe. IVIG, or intravenous immunoglobulins, they're given by a lot of centers in the United States for desensitization. It prevents the anti-A and the anti-B antibodies rebound in the early phase after transplantation, and it also believed to reduce the infection complication by substituting the depleted immunoglobulins that are good to prevent the infection. B-cell depletion. So this is removing the source. So you either do it by splenectomy, and we used to do splenectomy in transplants before the introduction of pharmacological anti-B cell therapies. Used to be an integral component for the reduction of B lymphocytes prior to the ABO incompatible kidney transplant. When rituximab was created, a lot of centers abandoned splenectomies due to surgical risk, increased risk of sepsis. And then splenectomy was substituted by rituximab. More recently, we stopped doing both groups, both strategies, either splenectomy or rituximab, because we have better strategies with less infectious complications. Okay, so inhibition of complement activation. So what happens is antibody binds to the antigen, but then this drug inhibits the activity or complement activation, which would lead to organ damage. So early reports for this particular protocol or use of the drug where an intentional simultaneous ABO incompatible kidney and pancreas transplant occurred. And then severe antibody-mediated rejection occurred in the patient due to antibody rebound. And then it was treated successfully with the eculizumab. So after that case report, we started thinking, what if we use this drug in a person who already has a lot of antibodies to prevent the activity of these antibodies before the transplant? So a single center study was created to evaluate the efficacy of the eculizumab when added to the conventional therapy. So in general, if you want to desensitize someone and force them to accept an organ with an ABO incompatibility, the typical process is we plasmapherese them until we have a very low level of titer. The issue occurs if the titer is still quite high despite plasmapheresis and the removal of antibodies. So the question is, can we add eculizumab to the regimen to prevent rejection or to force accept the organ? So this is what this study wanted to evaluate. Unfortunately, the study closed early on due to poor enrollment of patients. So this brings me to our own case series. So what we did is, this is our study a couple years ago. We used eculizumab to prevent antibody-mediated rejection for blood group incompatible kidney transplants. We had 4 patients. Patient 1 was the first patient that was used or that enrolled into this case study. All of these were ABO incompatible. Our patient population is typically obese, but this case series had a BMI anywhere between 20 to 45. A wide variety of cause for their kidney failure. Dialysis time was also variable. PRA also was variable, blood types. They all received thymoglobulin for induction, and the first one received about 10 sessions of plasmapheresis, but the rest received almost 3. Those are the titers. We have quite a significant titer post-transplant, pre-transplant, 1 to 64, 1 to 64, 1 to 16. This is the lowest titer that we had. The first case was a 48-year-old African-American woman with blood type O, donor with a blood type A, underwent 10 plasmapheresis sessions, but then the titer was still quite high. 2 weeks prior to transplant, we started immunosuppression with tacrolimus along with mycophenolate. 1 day prior to surgery, we started the patient on eculizumab, and then on specific time post-transplants. Patient discharged post-op day 6 with a GFR of 74. GFR about 1 year post-transplant was about 66. She did quite well. Based on that first case, we created a protocol. So the red line here is the time of transplant, and this is in days, 14 days before transplant up to 63 days post-transplant. So 14 days before transplant, immunosuppression was initiated, and the patient would receive 3 plasmapheresis sessions. No matter what their titer is, we proceed with the eculizumab the day before surgery. They receive a single dose of 1,200 milligrams. Of course, they receive all of their vaccinations about 2 to 3 weeks before the surgery. And then the day of surgery, they get the transplant, they get thymoglobulin for induction, the whole 5 doses. And then those time points is the time points when they receive the eculizumab. The last dose is 63 days post-transplant. The maintenance immunosuppression, we remain steroid-free of tacrolimus along mycophenolate only. This is our protocol. Those are the outcomes for our patients. The GFR was quite good for the majority of the cases. Case 2, unfortunately, had a lot of infectious complications of C. diff colitis, CMV disease. She was very high risk for CMV infection to start with, whether she received eculizumab or not. None of them had any meningococcal infection. One of the patients developed recurrent UTIs post-transplant. So based on this case series, we have created this protocol, and we have started having patients with ABO incompatible transplant receiving eculizumab. Now, why do we perform these kidney transplants? Because unfortunately, as I mentioned, there is a supply and demand issue. So if we do these transplants, we're giving a lot of patients a lot of immunosuppression. The question is, do these patients do well? What are their outcomes? Are we providing better outcomes, or are we exposing patients to a lot of immunosuppression with no benefit? The answer is actually there is improved survival. The only issue is it takes these patients a while to accrue that survival benefit. So in general, for a kidney transplant, they accrue survival benefit at about 8 months up to 2 years post-transplant, depending on the comorbidity of the patient and the type of organ they have received. In an ABO incompatible transplant or cross-match positive transplant, or in other words, in a sensitized patient, they accrue their improved outcomes about 3 years up to 5 years post-transplant. So to provide these transplants, the center typically provides a multidisciplinary team care, pharmacological PharmDs being on board, social workers being on board, very close monitoring for the first 5 years. And that's why if a patient does receive an ABO incompatible transplant, a lot of these patients don't go back to their primary nephrologist after the first year of transplant, because they're still considered very high risk and they require very frequent follow-up. Now, in general, there is no difference in the risk of urinary tract infections, CMV infections, or BK, or any PCP in the patients with ABO incompatible versus compatible kidney transplants. Questions? Thank you.
Okay, we're going to take another 5 to 10 minute break, wait for our next presenter, and wipe down the area. Okay, thanks for waiting, guys. Our next presenter is Dr. Alicia Ligvar. She is one of our transplant pharmacists. She's spoken at a lot of the National Kidney Foundation patient education programs. She's an excellent speaker. You will be definitely involved. She's very funny as well. And she's going to talk to you a little bit about updating in immunosuppression. So Dr. Ligvar, the stage is yours. Just click that to advance.
All right, perfect.
You can take that off.
I'll take this off, yeah. Hello, good afternoon, good morning. Hope everybody's doing well. I feel right at home lecturing to the camera and all of you remotely. My name is Alicia, or Dr. Ligvar, as David introduced me, and I'm one of our transplant pharmacists here at UIC. Today, kind of throughout my talk, we're going to be reviewing the basic principles of rejection and immunosuppression, describe some of the trends in immunosuppression therapies that we kind of see kind of around the country and around the world, explain the common side effects that we see with our anti-rejection drugs, and then kind of discuss some of the adherence challenges and patient concerns that kind of come to us following kidney transplant. So I know my lecture is kind of close to lunch, but when I think of immunosuppression, I think of pizza. Why do I think of pizza? Well, we all know that there are many styles of pizza. Me, being from the East Coast, I'm more of a New York kind of pizza girl. Thin, foldable, delicious, quick. But here in Chicago, we have whatever the lasagna monstrosity is, deep dish. I think of it a lot like our anti-rejection medicines, just because everybody has a certain type of pizza that they like. Some people like pineapples on their pizza, some people like olives, some people like sausage. And you'll see the same thing kind of goes with our transplant immunosuppression. There are different combinations that each center kind of picks for itself based on the patients that they're transplanting, and then also based on how they feel that combination is going to work best within that population. So when we think about our immunosuppression types, there are a couple different buckets that the anti-rejection medicines can fall into. The first is desensitization. So this type of bucket of anti-rejection medicines comes across when either we need to transplant incompatible kidneys or kidneys that are across different blood groups. So we need to bring out the bells and whistles, give a little bit extra anti-rejection medicine to make those kidneys more compatible together. Secondly, there is induction therapy, which is something we give at the time of transplant. I used to always think of this like preparing or clearing the field. I used to garden when I lived in Pittsburgh. So when I think of induction therapy, I think of if I were planting tomatoes, I need to get the soil ready. Much like when we give a kidney to a patient, we need to make the body ready. How do we make the body ready? We give induction. And that kind of clears out the T cells or alters the T cells so that the body accepts the kidney with a lower risk of rejection. We also have our maintenance therapies, which I think of like horse blinders. So our goal is we need to trick the body. We need to trick it into thinking that kidney's just been there the whole time. Right here, not where kidneys belong at all, the whole time. So we do that and we trick the body with our maintenance immunosuppression or our lifelong medicine, okay? And then lastly, let's say you do get rejection, or let's say there is rejection for a patient. There are rejection therapies, so that's the last bucket. You can find these rejection therapies in other areas, so such as some of the medicines we use for desensitization or induction, we also use for rejection. But I like to think of rejection therapy as like the factory reset. You know, when your computer's not working and you kind of have to unplug it and then plug it back in, that's going to be our rejection therapy to basically make the body forget and make it forget with medicine, okay? So for us, when we think about desensitization and how we can make our kidneys compatible, you know, a lot of times we go back to this study that was published by Montgomery and colleagues. Now for us, when we think about our patients that are waiting on dialysis, especially with the older allocation system, we know a lot of them are waiting and waiting and waiting and oftentimes died on the transplant wait list. So for us, the goal with desensitization is to lower the amount of antibodies that they already have, pre-existing antibodies, that allows them to have and accept more offers than what they would otherwise. Additionally, we use this when individuals come and have maybe a living donor that isn't necessarily fully compatible. We can kind of trick the immune system into making those living donor pairs compatible through desensitization therapy. So for us, you can see at 1 year there's no difference among the 3 groups, but as time progresses, those patients that don't get desensitization are still waiting for a pair. They're either on the transplant waiting list, waiting for a much longer time, or they are just not getting their organ. So for us, we have also an alternative to desensitization therapy, which is something that UIH is really piloting and really expanding through the help of our HLA lab and through our surgeons. So an alternative is a swap. I kind of think of it like kidney hot potato. So let's say you have this group of people, okay? You have SP, who's a 29-year-old. She's a donor, and she wants to donate to JT, who's a 35-year-old. They're unrelated, but they have a blood group mismatch. Second case scenario, you have JB, who's a 55-year-old, who wants to donate to his wife, SB, who's a 57-year-old, but they can't because they have preformed donor-specific antibody, which makes those kidneys incompatible. And then lastly, you have MC, who wants to donate to her brother, VU. For us, there might be no immunologic compatibility, but you have this situation where the 2 other pairs are. So for us, looking at these 6 pairs, we can kind of swap and figure out which pairs are going to be most compatible with each other and therefore swap. And then instead of having just 1 pair that achieves a transplant, we have 3 pairs. So for us, once we go through the transplant, we also have to think of, these patients are going to be on maintenance immunosuppression for life. So for us, what comes with maintenance immunosuppression, I like to think of as just baggage. So for me, I'm not a very light packer. If I'm going on a weekend trip, I'm going to have at least 5 different bags. That's just who I am as a person. Same thing for this maintenance immunosuppression. We think about all the medicines that they're on, the calcineurin inhibitors, have their list of toxicities, nephrotoxicity being the top. We just gave them a kidney, and yes, we're going to go damage it with the drugs we have to give them. The different metabolic side effects. For myfortic, we have our GI toxicity, our anemias, our leukopenias, so things that, oftentimes are rate-limiting steps in terms of patient tolerability of their meds. We also have in some programs, patients be on steroids lifelong. At UIC, we get rid of them, but if you think about the long-term side effects of steroids, you have osteoporosis, diabetes, weight gain, glaucoma, wound healing issues. We also have our mTOR inhibitors, or mammalian targeted rapamycin inhibitors, and they come with their own host of very different side effects: edema, anemia, like dyslipidemias, proteinurias. And then also we have our belatacept, which has different infusion-related issues and different cancer-related concerns also. So you have all these things, but how do you manage, right? If you just pick one, you have to use a lot of that one drug. Therefore, you run the risk of having a lot of side effects. But you have to think about it as a composite. Things go together in groups, right? So if we can use less of one drug by using less of another drug, we can kind of round out some of the side effects that we're seeing and overall create a balance for a patient. So for us, when we think about, what's that perfect balance, we have to think about 3 things on our stool, or 3 things on our scale, okay? The first being rejection, the biggest boogeyman in the room, right? This used to be what killed kidneys a long time ago. Before the advent of all these fancy drugs, okay? But we also have to think of toxicity, because you could have the perfect combination, but if a patient isn't going to tolerate it, they probably aren't going to take it right. So what's the point? And lastly, the other boogeyman in the room is, if you want to prevent rejection, you do have to suppress the immune system, but what comes with that is infection, and what comes with that is malignancy or cancer. So you have this triad, and you're just trying to find like what's the perfect balance on the bar stool to just not tip it over, okay? So to kind of think about, how do we get to these three things? We have a timeline of, kind of what we've done in the past. Kidney transplant is kind of not that old if you think about it, especially considering the entire history of medicine. 1950, it's not old at all. Initially, we didn't give medicine for kidney transplant. We just irradiated the graft, and that didn't work too well. Graft survival at a year was like 0%. Which is basically like my golf score. It's terrible. But like you think about how we kind of evolved from that, we borrowed a lot of drugs from the cancer world. We borrowed a lot of drugs from rheumatology. So azathioprine and steroids were really our next best guess, okay? And from there, we were able to improve. We could say, hey, we give you a kidney, flip a coin, it might work in a year. We don't know, let's see. And we're not talking like low doses of steroids. We're talking like big monster truck doses. So that didn't work too well either. So as things kind of advanced through the 70s, we could see that we started to develop antibodies such as thymoglobulin for induction therapy. And one of the biggest turning points for us was the advent of cyclosporin, which for the longest time was the cornerstone of what we used. Cyclosporin is a calcineurin inhibitor, and it basically took kidney graft survival to, let's flip a coin, to 80%. 80% is good for the 80s, okay? So from there, as things really started to pick up, in the early 90s, around 1994, we saw basically everything hit the market. 1994 I think of in terms of grunge music, and also tacrolimus. So for us, that's where we really perfected the art of how can we make a kidney work, how can we reduce rejection. So we were able to take our 0% from just 40 years prior to 90%, which is amazing. So for us, at that point, we got this like rejection thing down. Okay, we got this graft survival thing down. But we also have to think of, what are the other problems that come along with transplant at that point. So you can see, as we've kind of moved on, we have more and more novel immunosuppression medicine that have different side effect profiles. We have anti-rejection medicines that make things more compatible, whereas patients would be waiting on the waiting list. And then for us, we also have long-acting formulations which help our patients tolerate those drugs better and make it less of a timing issue. So big takeaway points from that little history lesson is calcineurin inhibitors work. They work. Tacrolimus is the more potent version of that class of family. And if you can see across all the organs, that's what's being used most predominantly. Tacrolimus also decreased our 1-year acute rejection rates to under 20%, which was unheard of basically prior to that. And then basically as a rule of thumb, cyclosporin is good, but it's also less potent. So thinking about how that all fits in together. History lesson number 2, triple regimens work. Triple regimens for the longest time were the cornerstone of how we envisioned a transplant immunosuppression regimen. So what that consists of is a CNI, either tacrolimus predominantly or calcineurin. You also had an antimetabolite. So for most centers, more than 90%, I would say, across the country today, we're using myfortic or mycophenolate over azathioprine. And then some centers will use steroid. About 50% of the centers across the United States currently use chronic corticosteroids after transplant. Here at UIH, we are an early corticosteroid withdrawal center, meaning by day 6, you are no longer on prednisone unless you are on it coming in the door, okay? So we try to remove that steroid from that triple regimen. And we're able to do that because we give more induction or upfront immunosuppression at the time of transplant that allows us to take off that steroid. So for us, history lesson number 3, much like a fine wine, much like a fine whiskey, we got better over time. We were really bad at transplant when we started, and we did not know a lot about the immune system. So as things grew and developed, you see as regimens change, our rejection rates basically went from 80%, basically everybody rejected unless you had a twin that gave you a kidney, to basically less than 20%. Same thing with our graft survival. It went from 50-50 flip a coin, to over 90%, which is incredible. So when we think of, how do you set the table for what an immunosuppression looks like? Most centers abide by the rule of 3 or the rule of 2. You always will have a backbone regimen. You'll always have an adjunctive agent, and then you might have steroids. So I kind of think of them when I teach our patients at the hospital in regards to superheroes. You have your backbone agent, that's Batman. Batman does the heavy lifting, he has the cool car, he has all the tools. Then you have Robin. Robin can't do stuff by himself. Trust me. There is like a comic about it. Didn't end well. This is your adjunctive agent, right? It helps out Batman. When Batman gets in a real pickle, you have Robin. Robin can't do stuff by himself. And then, depending on the center, you might have Batgirl thrown in there, okay? The end goal is to prevent rejection. So when we think about what's used as a backbone, predominantly, we do see tacrolimus and cyclosporin as our main Batmans, okay? Depending on the center, although not very common in kidney, you can see mTOR inhibitors like sirolimus and everolimus, but not the predominant. I would say less than 10% of centers. And then you have some centers use a novel agent called belatacept, which is a once-a-month infusion. That is a backbone in some areas too. Our adjuncts, again, are mycophenolate or azathioprine or sirolimus or everolimus. And then lastly, you have Batgirl, you have steroids, plus or minus, 50-50, depending on what center you're at, but not at UIH unless we absolutely have to. So what is rejection? So when we think of what the body does, our goal is to, again, make it believe that that kidney's just been there the whole time. So for us, what undoes that process? So there is these cells that float around called antigen-presenting cells. And for us, dendritic cells are an example of one of those many types of cells. And those antigen-presenting cells can present to T cells, and from there, they can trigger either the cellular rejection or the T cell rejection. T cell rejection triggers inflammation, it triggers tissue damage within the kidney. But there's also this crossover, the T cells talk to the B cells, and you can have this antibody process contribute to rejection as well through antibody-mediated rejection. And this is also bad because one, it's harder to treat. Two, it can oftentimes be very, very deleterious. And once we know a person has that type of rejection, the length to which their kidney will work is a lot shorter. So back up. So for us, thinking more about immunosuppression, what makes that kidney last and how our medications need to work is thinking about T cells. T cells are at the center of everything that we do from a medication perspective for the most part. And for us, when we think about our maintenance immunosuppression, we need to block T cell activation. So when we think about, well, what does that look like? That sounds really complicated. I made this figure myself when I was a resident, and it took a very long time to make. But it's easy as signal 1, 2, 3. Okay? So for us, we have this antigen-presenting cell that presents to the T cell. And when it presents, that's our signal 1. Now, I think of signal 1, a lot of things present there, but the T cell doesn't always need to do something about it, right? So I think of it like if you are shopping with a toddler or shopping with a small child, they want a lot of things to go in that shopping cart that do not need to be in the shopping cart. So for us, we need signal 2 to tell us, does this go in the shopping cart or not? Does the T cell need to act on this or not? If the T cell needs to act on it, that basically creates a downward process to which a cytokine by the IL-2 is made. IL-2 goes out into the universe and basically lands on other T cells at CD25. This basically tells those other T cells to activate the cell cycle, and you have this huge up population of T cells. So for us, when we think of how our drugs work, each drug that we use for maintenance immunosuppression works along this process. So immunosuppression is basically we can either get rid of the T cells and get rid of the B cells. We can divert or traffic control a little bit You'll be familiar if you've ever driven on Route 55 or 290 or 90. Same type of diversion. And then the blocking of T and B cell proliferation. So for us, we try to individualize as much as possible. We know that some immunosuppression isn't going to work as well for some patients as others. And we need to think about also what are those patient-specific risk factors. So we have our perceived immunologic risk. We can have our expectations or thoughts or concerns about drug toxicities. There can be history and non-adherence that we might need to overcome when we think about a regimen, different comorbidities, specifically cardiovascular, history of CAD, hypertension, diabetes, and then infectious risk. So when we think about our accoutrement of immunosuppression, we basically have our induction, and we need to think about it, are we destroying our T cells or are we traffic controlling them? So for our depleting agents, we have thymoglobulin or anti-thymocyte globulin, which is made from rabbits, or we have alemtuzumab, which is a monoclonalized human antibody. We also have our traffic control induction, which is our basiliximab, which basically prevents T cells from talking to one another. And if they can't talk to one another, then nothing is going to get done, okay? On the flip side, we have our maintenance immunosuppression. Again, we have our backbone or our Batman, tacrolimus, our antimetabolites, usually myfortic, sometimes mTOR inhibitors, plus or minus steroids. So for us, when we think about, where these agents work, for our induction, lymphodepleting agents, signal 1, thymo basically destroys a lot of the T cells, as does alemtuzumab. Basiliximab kind of works around that CD25 to prevent the T cells from talking to one another. And then when we think about our maintenance immunosuppression, we have our belatacept working at signal 2, our CNIs blocking the development of NFAT, so we can't make IL-2. And if we don't have IL-2, we have no way for there to be an uppopulation in T cells or an activation. We also have steroids that at high enough doses can work inside the cell to also kind of block that as well. Antimetabolites that basically block the cell cycle from activating. And then we have our mTOR inhibitors that basically we get rid of the traffic light. So the traffic light's always on red. So by this point, you're like, boy, Alicia, that's a lot of drugs. How do we know what combination's best? So for us, really we don't know. We get together once a year at the American Transplant Congress. Thousands of people come. This year it was very much virtual. And you have over 200 centers in the United States argue and debate about what is best. Like their protocol is the best. Their pizza is the best. They put the best pizza toppings on more than anybody else. So you have this, question of like, because transplant centers transplant different types of patients, accept different types of risks, believe different data to be more important than other data, you have this tapestry of what is acceptable and what's seen across the country. One of the bigger questions that kind of guide that is it less medication or less of each medication? So that's something that guides a lot of that discussion. So for us, the other thing we have to think of is, we can make a kidney last a year. That part's figured out. But the question is, how do you make it one transplant for life? And when we think about all the things that can go wrong, we can have chronic changes that can occur. So you can have chronic allograft nephropathy, which is an older term, which basically means scarring around the kidney through interstitial fibrosis or tubular atrophy. And when we think about that, we can think of things that are dependent on the immunologic nature, acute rejection, HLA mismatch, noncompliance, having antibodies form as a result. And then things that are more so independent of that process. So having, delayed graft function of a kidney that doesn't work right away, CNI nephrotoxicity, hypertension over time, all those things can cause a similar type of scarring. And then the other half of our patients pass with a functioning graft. Well, why is that? A predominance, actually by the numbers, you're not going to lose your kidney because of rejection. You're actually going to lose your kidney because you die of something else. You die of what everybody else dies of in the United States, and that's cardiovascular disease. So for us, a big question is, how do we mitigate that and how do we reduce those deaths as well? So for us, we need to think about, there are metabolic side effects of these different agents. How can we lessen them? So for us, we know our Rolls-Royce, our Batman, our calcineurin inhibitors, they all come with the risk of increased hypertension, diabetes, development of CKD through nephrotoxicity and dyslipidemias. But we can kind of look at some of the other options that we have to how can we lessen that? One of the things that we ask are, are steroids really needed? They're the oldest drugs that have been around. They were the OGs. We used them in the 50s. It's kind of like the Windex of transplant. If you've ever seen My Big Fat Greek Wedding, Windex fixes everything, steroids fix everything in transplant. But at UIH, at UIC, we really minimize our long-term exposure. So for us, we only keep them on for 5 days after transplant, and most do not stay on steroids after that 5th day. Patients who take steroids prior to transplant for whatever reason, such as lupus or other autoimmune diseases, we can't just take away the steroid. That does bad things to the body in other ways. So for us, we know that those steroids have to stay on. Also, if patients do have incompatible transplants and have to undergo some types of anti-rejection medications to make those kidneys compatible, sometimes we'll keep those steroids on after too, on a case-by-case basis. So for us, what we really see across all the organs, most commonly at discharge, historically at discharge, you'll see tacrolimus really across the board, mycophenolate or MPA generally across the board, and then, about 50 to 60% use of steroids depending on the allograft that you're in, okay? So the downside is, we got really good up until 1994, and then we've had no improvement with our long-term graft survival. I can drive a car for a year. Anybody can drive a car for a year. I mean, just don't let me on 90, but you can drive a car for a year. But what makes that car last to 10 years? You got to take really good care of it. Unless you have a Honda Civic, and then you can do whatever. But you have to take really good care of it. So for us, we got the 1 year thing down. But figuring out what's going to get a kidney to 5 years, what's going to get a kidney to 10 years, we're not doing so hot. At 10 years out, about half of our kidneys are gone. And realistically, we know that a kidney can last much longer. They should be lasting 20 years. So how can we do that? So what are our problems? An old problem is, for us, calcineurin nephrotoxicity. We worry that that's going to contribute to the scarring around the kidney, okay? Another type of thing that can cause scarring, or a newer problem that we have, is the development of antibodies. So if you have to back down on anti-rejection medicine, these antibodies can kind of crop up as a response. So for us, we have to think about, how much can we go down to kind of avoid side effects, but how much can we go down without causing antibodies? So for us, we also need to think about, what do these donor-specific antibodies, or DSA, contribute? And as you can see from this Kaplan-Meier graph, if you develop donor-specific antibodies, you're going to lose that kidney faster than people that don't have that. That's a huge problem. So for us, 10-year graft survival was 40% lower in patients with de novo or of the new donor-specific antibody compared to patients that didn't have that. And why is that a problem? Well, one, that could either mean patients are being non-adherent, or, patients, have these mismatches that we try to overcome, but at the end of the day, we still might have to challenge. But adherence, by and large, is the problem across the board. The new car effect wears off, much like I got a car, and by 3 months down the road, I'm just having fun on 90. So non-adherence is a huge problem when we think about our patient population. So for us, what does that look like? So our patients on average take about 8 to 9 medications a day, including some that might have been present prior to transplant if they were on insulin or blood pressure medicines. And we know that if patients don't take their medicine, exactly as it's prescribed, they can have a 7-fold higher risk of graft failure. So for us, immunosuppression non-adherence is reported in about 35% of patients in kidney land, in kidney transplant, compared to 14.5% in heart transplants and 6.7% in liver transplants. And that it increases from transplant, right? The new car effect has worn off. I'm not going to wash my car every weekend because I don't need to anymore. The 3 months that I've had it have been sufficient. Once a month will maybe do. So that new car effect wears off. Same thing when we think about our transplant medications. So what are the risks? So we know that it happens. How can we create a safety net to prevent it? So the high cost of immunosuppression is by and large a huge barrier for our patients when I worked in Pittsburgh, when I worked in Cincinnati, and since I've been here. For us at UIH, we have a medication assistance program, which if they're not canonized for sainthood, like with this Pope, I don't know what to say. They are incredible. They make miracles happen, and it can help our patients obtain access. Young age or perception of invincibility, we see this as a huge barrier in our pediatric transplant patients, especially when they transition to my parents help me take care of my immunosuppression to I take care of my immunosuppression. Living related donors, also, they haven't waited 5 years for a kidney. They've had a donor at their fingertips. So sometimes that can be a contributing factor too. Having any type of psychosocial issues, predominantly depression, huge risk of non-adherence. So making sure patients have adequate access to therapy, adequate and appropriate medications if need be. The perception that immunosuppression is not needed. If patients come to our pre-transplant clinic, they will not leave that interview with me until they realize that those meds are going to be for life. So for us, if patients don't realize that, and you tell them that at the time of their transplant, that's one, a huge wake-up call for them, but two, they might not have that buy-in that you need them to know that it's absolutely necessary. You also have a high pill burden. Again, 8 to 9 medications a day, multiple tablets, and then also drug toxicities. So if your medicine is making you nauseous and you can't keep down any of your meds, how can you be adherent? So I always think of the quote by Everett Koop, drugs don't work in patients that don't take them. So for us, we know on average about 23% of our transplant patients don't take their medications in some way that they are prescribed. So how do we define medication non-adherence? So if, I'm seeing a patient in clinic, for their pre-transplant evaluation, I really need to get at, what the World Health Organization classifies as risk factors for adherence. So we ask about socioeconomic, we ask about, look at their age, their gender, we have finance talk to them about their employment and financial status, patient and disease-related factors, treatment-related factors such as patient symptoms, side effects, and then healthcare system factors as well. So for us, when we think of the more transplant-specific things, we have this socioeconomic related, again, younger patients, male gender, having that invincibility complex. Sometimes our non-U.S. residents, again, due to insurance barriers or access to care issues, poor social support, or poor health literacy. For us, we also have medication or therapy related. So for us, this is kind of where pharmacy can help, complex medication regimen, higher medication toxicities. Again, lack of that medication education of, why is this so important? Or patients don't have a pill box or a reminder system. One of the things that I always like to ask when I evaluate and when I teach patients after they get their transplant is, how are they going to remember to take their meds? Because just keeping them on the kitchen counter in their bottles isn't going to be good enough for 90% of those patients. So a lot of times it's us, helping them with the pill box, filling the pill box together. I've set alarms on patients' phones so that they remember to take things the same time every day, because at least for the first 30 days, if you're not doing something consistently, it doesn't become habit. So if they haven't had that habit coming in the door, we need to create an ecosystem where they can have that. We also have patient-related factors, so psychosocial disorders, substance abuse, negative beliefs about medications are all barriers we think of when we think about, are they a transplant candidate? And if they are and they have these things, how do we adapt to teach them? How do we adapt to make that work for them? And then healthcare system and medication related. So medication costs or poor access to medications, poor physician or patient relationship. A lot of these things I don't particularly see a lot here at UIH, but we can see this if patients transfer or move across the state or move to, outside the, and have to establish care at a new transplant institute is kind of where you can see those things occur. So for us, when we think about their meds, I try to really sell 5 things. So empowerment, like this is their kidney. They can do it. A lot of people have done it before them. There are over 500,000 people that have gotten transplants in the United States, and they can do it too. But I also kind of want to have that healthy fear of consequence too. Like we gave you something very important, we gave you something very special, and how can we keep that very special thing safe? How do we get that kidney safe? Managing regimen demands. So we try to, every time I see a patient in clinic, my conversation for them is, how are you? What side effects are you having? Okay, we talked about your meds at the hospital. You knew them really well. Now you're in clinic. How's it been since you've been home? What problems are you noticing? And for me, I really just try to listen, Additionally, I also try to see, is there anything on their medication list I could change or adapt to help simplify their medication list and avoid over-medicating them. And then for us, having that social accountability and motivation, like sometimes when you get nauseous in the morning, how do you get yourself to take your meds? Or what's your process when you're having a bad day? So having them think of these backup strategies is also something that can help with their adherence and kind of motivate them to push through. So ways that we can also help our patients help themselves. I kind of go through what can they do to improve their adherence. For us, structure and habit and creating that and fostering that's really important. So I need to create some reminder cues for them. Where they keep their meds should be a reminder. How they keep their meds should be a reminder. Do you have a cell phone that's going to go off? Do you have a recurring calendar event? How do you remember all of these things? Involving family members or friends as a support system is also really important. For us, what that looks like in the real world is having husbands and wives oftentimes, be accountable for one another after the transplant. Again, simplifying the immunosuppression medication and then working to improve adherence when daily routines are upset. So for us, what we do to kind of help everybody remember is paper. Paper works really well. So every time someone has a change to their medicine in clinic or in the hospital, we give them this paper to kind of talk them through. We also have a medication therapy management clinic, which is pharmacist run. It is basically a pillbox clinic that teaches our patients, and then a medication assistance program as well, which navigates some of those financial concerns patients have as well with their meds. So for us, we also think about when we see our patients after transplant. Initially, we see them quite a bit. They're kind of sick of us, but that's okay. We're not sick of them. And over time, as they get less complex and we kind of dial in their regimen, we kind of graduate them to the Well Baby Clinic, the Well Baby Checkup Clinic, where everything's going great. We give them high fives, they're doing awesome, and then we just make sure everything is teed up like it needs to be. We also approach things from attacking all sides. So we want to, establish a new routine. Everybody adapted to this new COVID routine just fine. So if you can do that, you can adapt to a transplant routine. I believe in you. Financial assistance, making sure that from the get-go they're able to afford things. Having a support system, and then also patient and family medication all kind of go into how we think about medication adherence. So why, right? So not just, taking the meds, but also timing is very important. For tacrolimus, I think of it like Goldilocks. Levels can be too high, side effects. Levels can be too low, rejection. And then levels can be too variable, and that's really bad too. So for us, I really stress that, when you think of your anti-rejection meds, it's just like having your coffee the same time every day in the morning. If I don't have my coffee by 6 o'clock in the morning, everyone's going to know about it. especially my husband. Especially my husband. So for tacrolimus, it actually also matters too. So if you're taking your tacrolimus at every time during the day, you're going to have really erratic levels. And that's actually very bad. So for us, you look at, well, how bad is it? It determines how long that kidney works. It determines how much miles you got in that kidney. And if you have variable levels, that's going to decrease the mileage over time because it's going to increase the scarring that we see. So again, having erratic levels, not taking things the same time every day, we can see this chronic scarring occur as soon as, 3 months to 2 years after the transplant. So for us, that also, means that we have these late outcomes that are not what we want. Graft failure, late rejection, kidney scarring. So timing is actually very, very important. We also know that the time that your tacrolimus is within its goal range is also very important. So we ask a lot of questions about what time you took your dose, how often are we getting levels, because the time that you're in that happy zone also means your kidney is going to last a lot longer. So for us, patients might hem and haw about labs, but we know that time matters when we have the levels where we want them to be. And we only know that really for the tacrolimus. We don't have that other data for the others, but we can imagine it's pretty similar. So when we step back from all of that, when we ask patients, what is your biggest concern after transplant? Or I ask, at a first teaching, is there anything that you're afraid of after transplant? A lot of times I've heard that patients are on like 50 medicines for the transplant, and like, how? So for us, I really kind of go through, my MO is to only keep you on what you absolutely need to be on, and we're going to go through this medicine list of what you're on, what you were on before, why you don't need to be on maybe those medicines anymore because your kidney works. What have we added? Why have we added it? The why is so important. So for us, it's not 50, got to round down, 8. 8 meds is what the average kidney transplant recipient takes. For us, that might mean multiple tablets of a medicine. Like my Fortic is 720 milligrams twice a day, but the manufacturer makes tablets that are 360 milligrams. So you're going to be taking 4 tablets a day, 2 in the morning, 2 in the evening. So for us, we really work with the patients to really schedule things out to make sure that they're comfortable with how they're getting their meds. We have people that are truck drivers, we have people that, and patients that, have demanding daytime jobs. So trying to find a schedule and a regimen that works for them is really important for me. So again, when we think of, our meds, how many again? I like to tell them, the list that you leave with is probably going to be the longest list after your transplant. And the reason for that is we have to give you a lot of extra things because we gave you so much anti-rejection medicine in the operating room. So we have to give you things to prevent infection. We also have to give you things to prevent things like hypertension or high blood pressure, control your blood glucose, and then think about other tasks that the kidney does. In addition to that, we also want to make sure our patients aren't leaving in pain. So talking about pain control and pain expectations, and then making sure they're having like a normal bowel regimen after the surgery is also very critical. So for us, what is the role of the transplant PharmD? So for us, we know that when we think about our transplant outcomes, we want to make sure that centers are achieving what they're able to maximally. And making sure our patients are comfortable is like only a component of that. If your patients are comfortable and they're confident, then you're going to have good outcomes because they're able to, let you know when things are wrong. They're going to feel like there's an open line of communication. And our role is kind of fostering that communication. So we want to advocate, for the appropriate use of anti-rejection medicines. We also want to manage those drug toxicities because sometimes the regimen that we go with first, based on our protocol, isn't maybe what's going to work best for the patient. So thinking about those toxicities and comorbidities is very important. Our job is also required by UNOS and our OPTN, and every single transplant center has to have a version of us because our job is associated with, the long-term involvement, helps, that acute care management, helps the pre and post, who is a candidate, what can we do to make that recipient as successful as possible. And we're also seen in the hospital and also the clinic setting. So what that looks like for us is, we see patients in the pre-transplant setting. I'm, as you can tell by my white coat and my fig scrubs, I'm in the transplant ICU today, managing and helping our patients understand their meds, getting them ready for discharge, and also fielding incoming transplants to get them ready for the operating room. Outpatient, we will see them, make sure everything is going as expected. We also manage any readmissions within our transplant team. And then we have outpatient. We also want to make sure that they're maintaining success with their lifelong transplant management. So with that, if there weren't any questions, I will open the floor for questions. So thank you all for joining in at home. And thank you very much.
No questions.
No.
Just lots of love your animation and
They like the pizza. The pizza's always a win. I'm really hungry now. I could talk about how much I hate driving on I-90 for like days. It's probably not fair. Thank you.
Okay, we're going to take another 5 to 10 minute break and set up for the next speaker, as well as doing a wipe down. Thank you. Okay, our next presenter is one of our transplant surgeons, Dr. Mario Spaggiari. He's going to talk about the hindrances of kidney transplantation and specifically obesity and vascular complexity. So, Dr. Spaggiari. Just hit that button in advance.
Thank you, David. Yes, today I'll be talking about two very challenging situations in kidney transplant, yet very common, that are obesity and vascular complexity. So first of all, I would like to start with the contraindication to kidney transplantation, that here are divided by medical, surgical, or others. As you can see, others are complications mainly, socially related, social status related. The medical contraindication, beside active infection, are contraindications that unfortunately, most of the time are absolute, so nothing we can do about it. The surgical contraindication are relative contraindication. Unfortunately, we have many patients that have been ruled out from kidney transplant for this complication, but with the right technique and with the right approach, I think they could be overcome. And that's pretty much my presentation today. So let's start with obesity in kidney transplant. So first of all, as everybody knows, obesity, it's a condition that is becoming way, way more popular. Obesity is an issue when associated with end-stage renal disease because the mortality on dialysis is very high, because obese patients with kidney disease, they have a very difficult access for dialysis for many reasons, and the results of this condition is a low survival, for this type of patient. And talking about dialysis and obesity, well, I would focus on the patient under 65 years of age. That is pretty much, the average age of a kidney transplant recipient. As you can see here in the bold line, so the higher is the BMI, and the higher is the mortality on dialysis, to the point that if you have a BMI that is 35 or above, your chance of dying on dialysis pretty much doubled. And let's talk about the obese patients that are actually active in the transplant waiting list. So what happened to them? Well, that's a very interesting study published by the group of Johns Hopkins. And what you can see here is that if you are obese with a BMI of 40 or with a BMI between 35 and 40, your chance of getting transplanted over time, it's much lower. It's much lower, and this means that at 5 years, if your BMI is 40, your chance is half. It's 50% of a chance of a normal weight patient. Well, it's difficult to tell what is the reason for this. We can speculate that, for example, these patients are active in the waiting list, but when they receive an offer, they've been passed, they've been skipped. They could have been skipped for many reasons, because of course the technical challenge, because the surgeon on call doesn't feel comfortable to do this particular case, or for example, this could be patients that are active in the waiting list, but they have been asked to lose weight in order to get transplanted. And losing weight when you have a BMI of 40, when you are dealing with dialysis, this means that you are dealing with low blood pressure, with 3 hours in a dialysis chair 3 times a week. Well, that becomes a challenge that it's very difficult to overcome. And here, there is a very interesting correlation. I will go into details in the next couple of slides. And this is a correlation between obesity and surgical site infection. Well, as you can see clearly, so the higher is the BMI, and the higher is the chance of developing a surgical site infection. And why this matters so much? Well, there was a study published in 2009 in Annals of Surgery that basically took into account all the potential risk factors for a poor kidney transplant outcome. And they consider also, of course, obesity, but what the study clearly showed is that what really matters is the incidence of surgical site infection. So if you develop an infection in your surgical wound, the chance that your kidney may fail sooner rather than later is actually higher. And here, what we can see, so here we have patients who had surgical site infection with a BMI less than 30 or more than 30, that mean obese, and patient without surgical site infection, still stratified by BMI. If we see the survival rate of the graft here, what you can see is that the best survival is for patients without surgical site infection, regardless of the BMI. And similarly, the poorest survival is for patients with a surgical site infection, regardless of the BMI. In fact, the worst outcome is for patients with a normal BMI, but a surgical site infection. So the hypothesis that we formulated in 2004 was, what if we change the technique, the traditional open kidney transplant technique, and we start offering something different, something that could potentially prevent surgical site infection? And that's when we started offering robotic kidney transplantation. And I'm very glad to show today the results recently published in American Journal of our 10 years experience. We are talking about 239 patients, and as you can see, most of them were African American. And interesting, you can see here that 46% of our population had a BMI that was beyond 40, and that's very interesting because we transplant pretty much 50% of the morbidly obese population in the United States. So basically, they account for almost 50% of the nation population. Talking about the cause for end-stage renal disease, these are the most common causes that are diabetes and high blood pressure. Here, in this very crowded slide, I just wanted to show you what was the surgical site infection rate in our study. It was extremely low, in fact. It was 0.4%, and if we further stratify by BMI, you can see that for the highest BMI group, so 40 to 50 and beyond 50, we actually didn't have any surgical site infection. And this is another very interesting slide. So here we compare our results with the UNOS data, so with the national results. We have two groups. We have the group of people who received a living donor kidney transplant that we know very well that in the long term they do better. These kidneys, they stay around longer. And we have the group of people who actually receive a deceased donor kidney transplant. For the two groups, we have our population and we have the UNOS data, the UNOS population, that means the nation population. As you can see here, the two curves, they absolutely overlap for living donor and for deceased donor. What does it mean? It means that with the new technique, we are able to offer kidney transplantation successfully to people that are commonly denied access to transplantation. And this is the patient survival, and it's very similar situation. As you can see here, the patient survival is absolutely similar, if not better. And now I want to show you actually the technique. And let's see if it plays. There you go. So this is a recent kidney transplant that I did. And we start the procedure dissecting the external iliac artery like we do in open kidney transplantation. Everything is done robotically, as you can see. Once the artery is dissected, we retract it with a vessel loop in order to facilitate the dissection of the external iliac vein that you can see here. Then we clamp the vein with robotic bulldog. We perform a venotomy with scissor. And then we bring the kidney inside the patient, inside the surgical field through a short subxiphoid midline incision. And we start the anastomosis. Once the vein is finished, we move to the artery. So we clamp the artery proximally and distally with robotic bulldog. We perform an oval-shaped arteriotomy with scissor. And then anastomosis. So now the kidney is ready to be reperfused, almost ready. Okay, so that's the reperfusion of the kidney. You will see the cap. There you go. Now we check the perfusion of the kidney essence that you will see in a second. And then the next step is the ureter anastomosis. Of course, everything is done from inside. We connect the ureter to the bladder. Okay. So, in conclusion, robotic kidney transplantation is an effective approach to reduce wound complication in obese recipients and allow safe and successful transplantation for patients that are previously and still denied access to transplantation. But then the next question, I think it would be what we're going to do about the weight, about the obesity itself that we know that can potentially jeopardize the patient down the road, and then can actually jeopardize the transplanted kidney down the road. And the reason is because obese people, they have what is called an obesity-associated nephropathy. It's a sort of hyperfiltration of the native or transplanted kidney, then down the road, of course, can lead to end-stage renal disease. So in order to grant our patient long-term good outcome of their transplanted kidney, we have at some point to address the weight. So we started recently, a couple of years ago, to offer patients combined robotic kidney transplantation and sleeve gastrectomy. We achieved two goals at the same time. We take them off dialysis, and at the same time, we started dealing with the extra weight through the bariatric procedure with the help of our colleague. This is the algorithm, the decision-making approach that we have been using. That to explain it easily, so if we have a patient that has a living donor that basically could go for transplantation sooner rather than later, well, in this case, we offer them the combined approach. If we have a patient that doesn't have a living donor, so he may have to wait in the waiting list, we'll see when the patient started dialysis. If he started dialysis more than 3 years before listing, we offer them the simultaneous approach because we know they will go for the transplant soon. Otherwise, we can do the bariatric surgery first, wait for the patient to lose weight, and likely by the time we will be ready to get the kidney offer, he will have hopefully a normal weight, and then we can proceed with the traditional open kidney transplantation. Even in this case, we recently published the results of our pilot study. It was a randomized study with 25 patients enrolled. 14 were enrolled in the simultaneous procedure, robotic kidney transplantation and sleeve gastrectomy, and we had 11 control. this was our population. As you can see, 72% of our patients had a BMI between 40 to 50. Even in this case, the majority were African American, and half of our population had diabetes as the leading cause for kidney disease. And this is the interesting data. So here I can show you the two groups. So this is the kidney transplant only group, and this is the kidney transplant plus sleeve gastrectomy group. And the delta BMI means the change in BMI over time. We have 3 checkpoints, 3 months, 6 months, and 9 months. And what you can see here is that people who had, so recipients who had the combined approach, they lost more weight over time at each checkpoint. And how this reflects in the kidney performance, in the kidney transplant outcome. This is the glomerular filtration rate. Here, as you can see, we couldn't reach a statistical significance, but that's also probably, because of the small samples in our study. But here, what you can see is a trend. You see that people that lost more weight over time, they tend to have a better GFR at 36 months. And for this reason, we think that combining robotic kidney transplantation and sleeve gastrectomy these days is the way to go, and that's why we started offering these two procedures combined to every patient that, of course, is interested and has a BMI that is beyond 40. And now I'm going to move to the next topic, that is the high vascular complexity and kidney transplantation, another topic that is still very common, and another topic that unfortunately rule out many patients from transplantation. It's very common because, as I showed you before, one of the leading causes for end-stage renal disease is diabetes and high blood pressure, or the combination of the two. So many patients, when they get listed, when they finish the workup, they have aortoiliac arteries with this particular shape, so full of calcification. And in many centers, because of this reason, patients are ruled out from the transplant waiting list. Here, similarly to what we did for obesity, we just combine two procedures and we still offer patients to receive a kidney transplant. And these are the results of our recent study. It's a retrospective analysis. It's a match control analysis of 23 patients over a 5 years period. And what we did in this case, we perform an endarterectomy. We replaced the anterior wall of the artery with bovine pericardium that we found be an excellent prosthesis because it's resistant to infection. He has a very good vascular compliance. And after we replace the artery, we do the endarterectomy, then we proceed with the kidney transplant. And these are the results of patient survival and graft survival. Even in this case, we couldn't get any statistical significance because of the small sample, but that's why we did a match control analysis. And there was no difference in patient survival between the patient who underwent endarterectomy and kidney transplantation and patients with the same demographic characteristic, but who didn't have a peripheral vascular disease. And even this procedure now became the standard of care, and we don't rule out any patient for vascular calcification. And then I move to the next and the last challenge in kidney transplantation, that is the iliocaval thrombosis. So I want you to see this picture. This is a transplanted kidney. So every time we transplant a kidney, we need to connect an artery and a vein. The vein, 90% of the time, is connected to the external iliac vein, that is this one. If this is not viable, we can move to the common iliac vein, we can move to the IVC, but unfortunately there are few patients, it's a rare condition, that don't have the iliac caval system. Most of the time, these are patients who have what we call thrombophilia, so they tend to develop clot, and they lose completely this venous system. In this particular case, of course, the struggle is to try to find an outflow for this kidney. And what we offer for our patient was to place the kidney instead of the spleen. In these particular cases, so we perform a splenectomy, we remove the spleen, and we use the splenic hilum vessels to connect our kidney. This looks like a spleen, but it's a kidney, and this is the same one seen in a coronal projection. We perform 4 of those cases in people that in half of the cases had a thrombophilia. In one case was lupus related. In the second case was an hypercoagulability secondary to anticardiolipin antibodies. As you can see, all patients were discharged with a normal or almost normal creatinine. And in the long term, every patient had a normal creatinine. In conclusion, minimally invasive kidney transplantation lessens an important barrier to the most efficacious treatment of end-stage renal disease, and the association of kidney transplantation and bariatric surgery is the key for excellent long-term results, and we believe that the benefit of kidney transplant should be granted to patients regardless their BMI or their vascular complexity. Because the techniques are there, they should be implemented, and they should be used by every transplant center. Thank you very much.
We're going to do a quick wipe down, and our last presenter is here. So we're going to be done very early, which I'm sure everyone's liking. Gotten other emails regarding our CEs and certificates. Everyone's email that has been registered and actually came in this morning that said that they registered, but they never got the link, but they're watching with a group of people and so forth. I will definitely send out the post-test as well as the evaluation. So everyone will get their certificate and get their CEs, okay? Not to worry. And if there's any problems or issues with the post-test, then you guys know how to reach me, okay? All right, so we're gonna do one more wipe down, and then we're gonna bring in Dr. DeCoco. Okay, we are. Last presenter is probably one of the busiest men and unsung heroes of our transplant team. That's Dr. Pier Paolo DeCoco, who's actually our procurement surgeon that goes out and procures the organs. So he is going to talk about the donation process and the organ procurement process. So Dr. DeCoco.
Can I scroll this?
I don't know if it works that way. No, okay.
It does. Good afternoon, everyone. My presentation will focus on donation process and organ procurement with the aim of understanding the process of donation from consent to recovery of organs.
I will give an overview on solid organ transplantation, donation process and organ procurement, brain versus cardiac death protocols, donor screening and organ-specific testing, allocation of the organs, and lastly, organ procurement. Solid organ transplantation, considered a medical miracle of the 20th century, is now an established and the best treatment for modality for many patients with end-stage organ disease. That's the situation we're facing today, and actually over the last 2 decades, there has been an increasing number of patients waiting for an organ with a steady or slightly growing number of solid organ transplants. Last year has been a record-breaking year with over 39,000 solid organ transplants done in the United States, which is 8.7% increase compared to the previous year. Nearly 7,400 living donor transplants were performed all over the United States, and 11,900 deceased donors. That's the situation today. Per UNOS data, 111,000 patients are still waiting for an organ, which is a life-saving organ for them. In order to address the nation critical shortage of organ, in 1984, the US Congress passed the National Organ Transplant Act, NOTA, with the aim of establishing organ procurement transplant network in order to maintain a national registry for organ matching and United Network of Organ Sharing, which is a private no-profit organization under federal contract. Up until now, UNOS is the administrator of OPTN, which is under the contract of HRSA of the US Department of Health and Human Services. Important federal agencies as CMS, CDC, NIH, and FDA are responsible for the regulatory process. That's the UNOS regional map, which is how the organ procurement and transplantation network in the United States is organized. We have 11 regions, and in those 11 regions, 58 organ procurement organizations are responsible for the whole process from consent to donation. Those are non-profit organizations mandated by federal law. All this complex structure is makes the field of organ donation and transplantation one of the most regulated areas of the healthcare today. The goal is providing the safest and most equitable allocation, distribution, and transplantation of organs. As we see, the donation process for us, which as transplant surgeons, we do see only the last part, which is procurement and transplantation, but as a background, there is a multi-step process which involves the work and the dedication of many professionals. Everything starts with education, medical management of the very sick patient, consent for donation, declaration of death, and so forth. Everything starts, all our jobs start with a willingness to donate from a donor or the donor family, which is the only hope for thousands of patients which are waiting for a life-saving organ. Going to the second part of my presentation, disease donation is broadly classified in brain and versus cardiac death donors. The neurological exam will dictate which pathway, which protocol will be applied. Brain death donors are those individuals who unfortunately suffered irreversible loss of all functions of the brain, including brain stem, and is usually secondary to severe brain injury from trauma, cerebrovascular accident, anoxic event, and so forth. In the United States, the declaration of death is mainly clinical, with apnea test being the most important test. Only occasionally, if the physician is not able to declare that, confirmatory or ancillary tests will be required. How the brain donation protocol works. So there is a declaration of that from the hospital physician. Once that is declared, the OPO coordinator works with family, with the medical team in order to identify a potential donor. If there is willingness from the family or from the donor, all the process starts. And it's OPO in their mission is to maintain the donor hemodynamically stable in order for the procurement to happen. And transplant team is involved only in the procurement phase, so in the last phase of the process. Key points in donation after cardiac death: time of death is a legal time of death, so there is no confusion between brain death and coma. Brain death is irreversible, and the donor is maintained cardiovascularly stable by intubation and eventual Presso's requirements, so in order to perform, to allow the procurement to happen. In the donation after cardiac death, those are protocols applied to patients which suffer catastrophic brain injuries, which are not particularly, they don't fulfill the neurological criteria for brain death, but still the severity of disease, it's will allow withdrawal of life-sustaining treatment on the ground of best interest. There is a classification, which those are broadly defined as uncontrolled or controlled donors, and the widely used classification is the Maastricht, which 5 classes. In the United States, most of the donors are controlled in Maastricht 3, so patients which are awaiting for cardiac death. And the slide summarizes was the action during the donation after cardiac death. So family consent to withdrawal support. At this point, the OPO will talk with the family and gather eventual willingness to donate. If there is willingness to donate, the OPO and hospital staff will work together in order to withdrawal, what we say, to proceed to withdrawal of treatment, which is usually done in the operating room or in the ICU setting. After this phase, there is a so-called agonal phase. So the donor will go, is totally unsupported. If goes into a systole, the hospital physician will then wait 2 to 5 minutes, depending on the hospital regulation, which is a no-touch time. So after this time, we'll eventually declare death. And at this point, we start our procurement phase, which is procurement of organs. So key points of donation after cardiac death will be only discussed with family after the decision to withdraw treatment. So there is nothing to do with a medical decision to withdraw treatment. The recovery of organs is completely different from a brain death situation. And if the donor doesn't expire, doesn't die in a certain time, which is usually 2 hours, depending on the organs, the organ donation is no longer possible. Donor screening of organs, it's paramount importance, and every donor goes through a series of tests which will be detailed later in order to rule out infection or malignancy, minimizing risk of transmission to potential recipients, and those protocols will follow OPTN FDA regulation. It's particularly important nowadays with our pandemic of COVID. So everything starts with a medical and social history interview. Usually is conducted to the next of kin, where there will be highlighted eventual risk behaviors, relevant travel history, or donor past medical history for a risk stratification. To follow, there will be serology testing, which is standardized in order to see if there is any infection or potential malignancy, and imaging studies. Blood type and HLA testing are performed in all donors in order for tissue typing and histocompatibility purpose. Specific organs allocated will require specific testing, and we have highlighted here the main tests which are done in different organs. Heart, for heart we have echocardiogram and cardiac cath. For lungs, most commonly done is a bronchoscopy after the chest X-ray or CT scan. CT scan, which is done to evaluate abdominal organs, and kidneys and pancreas will also have specific testing. And the allocation of the potential organs will follow the generation of the list from which is done following UNO-specific guidelines. OPO coordinators and transplant coordinator work closely together in order to make in order to define the process together. And there is a time frame of 1 hour rule to reduce the timing of donation. From the time the transplant coordinators are informed about an offer, there is a 1 hour rule that they have to follow in order to keep time the closest possible. So multiple people are involved in the allocation. It can be time consuming. Multiple offers are done at the same time. Surgeons may need more information, and it's not unusual to have donors for 1 or 2 or 3 days before allocating organs. Once the allocation is done, procurement may start. This is a surgical procedure of removal of organ or tissues in order to, with a goal of organ transplantation. It is supported and coordinated by OPOs. The procurement, we do usually operate in different hospitals with new staff, and it's important to have coordinators that that can make our job easier, going in places which we don't know and we don't know the staff. It's important to optimize the process. Of course, it's done in the operating room. Potentially up to 8 teams work together, so it may be pretty busy. And everyone has in mind respect of the donor and with the intent to procure organs that can be transplanted. I like this picture because we'll depict how usually the team waits and everyone is focused on their step, and there is no confusion in the room, which is not always the case, but it's how we tend to work. The operation is 4 to 6 hours. There are involved abdominal and thoracic teams, and is and divided in 3 phases, major phases. A warm phase where the donor is maintained. This is a standard DBD donation process. In a warm phase, so the cardiocirculatory support is given by the anesthetic team, and the dissection of the organs it's done by the different teams. This is in preparation for what we call cross-clamp phase, which is once the organs are perfused with special preservation fluids, and they are submerged in ice in order to reduce metabolic demand and preserve the organs. In preparation for the last phase, which is the cold phase, is where we intend to remove the organs as fast as possible, because there is ischemia time that will not could potentially jeopardize the function of the organs. So this phase has to be fast and has to be done in a structured way in order to avoid delays and damage to the organ. Immediate transportation and transplantation will follow. with always in mind our goal is to save another human life by means of transplantation. Thank you for your time. Yeah.
Okay, this question is from Holly. Was there any reason as to why gastric sleeve technique was used? Were there other bariatric surgery methods discussed?
That's
Oh.
Okay. All right. Thank you. Thank you.
Thank you. Okay, that is it. We finished an incredible time. Again, I will send out tomorrow late afternoon, early evening tomorrow. Check your emails for the post-test. Once the post-test is completed, it automatically grades itself. They send the results back to me, and then I will send out the link to the SurveyMonkey for the evaluation and certificate printing for the nurses and the social workers. The dietitians and the techs will be sent their certificate from me via email. Thank you for attending. Hopefully we'll be meeting face-to-face next year. God bless you all. Stay safe, and we'll get through this, and looking forward